to ask a question. Today's conference is being recorded. If you have any objections, you may disconnect at this time. And now I'd like to turn it over to your host, David Dela Cruz. Thank you very much, sir. You may begin.
Thank you. Welcome, everyone, to the Day 2 of the Secretary's Advisory Committee on Infant Mortality meeting, December 5th, 2019. I hope everyone had a nice evening, got a little time to relax and rest a bit. We have a full agenda in only about a 3/4 of a day. So without any hesitation, I'll turn it over to you, Dr. Jares.
Okay. Well, thank you. Good morning also to everyone on the phone, both committee members and appreciate any public who may be listening in. We'll have at around 10:30 a public comment period, so hearing from you at that time. Our chair is doing well, and for those of you who know, when he can walk around and saying hello to everybody in the place, so that's good news. Today, the first thing on our agenda we probably should get to is the minutes approval, because we didn't get to that yesterday. So if everyone has had an opportunity to review the minutes, we'd like to go through a process of approval.
So this is David. So I did get comments from Dr. Hogan. If anyone else has any other significant comments, let me know. Otherwise, do we have a motion to approve the April 2019 meeting minutes? Dr. Hogan, and do we have a second?
Second.
Oh, all right. Dr. Wise. Very good. So any objections? Okay, let's consider them accepted. Thanks, everyone.
Very good. So our next agenda item is a recap from day 1, and I can get started, and then we'll open to comments. I thought we did a very good day. I had a good day. Lots and lots of information, overwhelming almost, and so I know we've all taken lots of notes. With regard to the content of the day, we did have a setting the context section where we did look at the new charter and could see really the trajectory of the movement over the committee for years, including now explicitly women's health, a life course, both of a life course, and also the importance of focus on the maternal-child dyad and the interrelatedness of maternal health and child health. The centrality of health equity is reflected as we go forward, both with regards to social determinants, but also the toxic effects of racism systemically, historically, and institutionally on women as a clear explanation for, or as one of the clear explanations for the disparities we're seeing. So with regard next, we had a nice welcoming from Tom Engels, the administrator. It was good to hear from him and learn of his experience in Wisconsin with many, many different social services, health and social services. We went through some one-on-one, there was also the one-on-one interviews with SACIM members that Dr. Ellinger went through, and I think there was a fair amount of consensus among the committee, both the realization that we have a responsibility and an opportunity to help set a direction for maternal and child health, and also to make sure that we are looking at actionable things that can be done, and it just doesn't become a committee of filing a report. And I think there was a high level of support for that. We did review previous SACIM recommendations, including the 2013 report and the big ideas section of that, and one of our tasks for ourselves overnight was to review that a little in more depth to see what was behind the 6 big ideas and see if it did or didn't include some of the components that we thought should be in there. Had excellent presentations by the Maternal Child Health Bureau, which really talked about the many investments in maternal child health as well, both for home visiting, Healthy Start, and Title V, and some of the progress they're making in those regards and the new directions. we then heard from the CDC, Charlene Krolinger, about really the systemic way the CDC is building a network of perinatal quality collaborators across the country, and also developing a national system of maternal mortality review committees with a standardized data collection tool called Maria, which will be a real development for us. And of course, much of the CDC information was reviewed with us, which continues to show that despite all our efforts, we're seeing increased rates of maternal morbidity and mortality and increasing rates of preterm birth. We also heard from the March of Dimes, Becky Abbott, the Director of Federal Affairs, who gave us a policy update, many important policy issues regarding maternal child health, including the PREMIE Act, and then also discussed the March of Dimes prematurity report, which again unfortunately shows increasing rates of preterm birth and increasing health disparities across the nation. So all these are really a call to action for us. We spent some time reviewing what the SACIM, what recommendations have been made in the past, how we should modify these, how we should go forward, and one of our tasks over the evening was to think about some urgent opportunistic ideas that we could brainstorm to start focusing down on our work. So with that, I'd like to ask members of the committee if there's anything I missed or anything you'd like to restate in summary of yesterday, both on the phone and in the room. The operator, you said you do whatever we ask. Can you bring in a pot of coffee?
Oh, yes, I would love to do that. I was waiting for the room to proceed first. As a reminder, anyone on the telephone, if you have a question at any time, press star then 1. That'll get you in line. And please take a moment to record your name. Star then 1. Presently, I have no questions in queue. Thank you very much, Doctor.
Okay, thank you. So let me get to today. If we could show the slide of the meeting objectives, I'd appreciate it. Ed had set out some meeting objectives, which was on the back page. Oof, this is an eye test. Okay. Yeah, please, if you could blow it up as much as possible. And he had 3 major meeting objectives, which we can look at here. Obviously, without him being here, we tried to divine his intent and do the best we can. But I would like to look at these today so they can inform our work of today. Objective one was really to identify and utilize immediate opportunities for action to fulfill the charge of the committee in the next year. And I think this is something we'll talk about later. That was our little task overnight, to think about what those things are. And of these 3 objectives, I think that's the one we really have to hit on. And if we can do that, come up with a preliminary list of ideas, I think we've had a successful meeting. Objective 2 was really expanding our shared knowledge about opportunities, understanding of issues, initiatives that are ongoing, influencing the health and well-being of mothers and infants. And I think yesterday we got an excellent start on that with the presentations that we received, and we will have additional presentations today. At the end of the meeting, I think we have a discussion also about what further information we may want in the future. What future presentations or work the committee is aware of to make available to others. Third objective, establishing a framework, strategy, organizational foundation to execute our charge. I think this is something that may take us a little more time. I would doubt that we'll get through that today. We had lots of information presented over the day yesterday and will today, and I think we're going to need to take some time to synthesize that into something that can guide us over the next couple of years. Once again, I'd like to pause now and ask for people's ideas. I guess the proposal I'm putting forth is that we particularly focus on Objective 1 today, but that's a proposal for you to react to.
Let me just jump in real quick. So I would recommend that you don't limit your recommendations to just the secretary. I think it's absolutely appropriate that you also make recommendations both to HRSA administrator and also to the Dr. Warren, the MCHB director.
Yeah, very good point. Although if we do make it to the secretary, it will get tasked to Michael Warren anyway. So but you're right, we should. So can anyone enlighten us further about where to go today and with the meetings? Magda, you're on the phone. I'm counting on you.
I am, and I want to first of all just take a moment to thank you, Paul, for stepping in and stepping up. I think when you mention we're going to try to divine his intent, it's really about solidifying our own intent. And so I very much appreciate your being the interpreter and stepping into this role in an unexpected time. So just on behalf of all of us, Paul, thanks so much. I would be very curious if, as you said, if there was a chance to harvest around the room and on the phone, what might be the most immediate opportunities to seize from what we know professionally, from what we have heard, and I would be eager to hear from my colleagues as well as from the ex officio and other members participating about what is within our sights now, so that we can do something that continues to move the momentum forward. So I just want to underscore that particular point, to be pragmatic and to be strategic. Thanks, Paul.
Comments or questions? Correction. Okay. So we are a little ahead of time. At about 11 o'clock, we had scheduled really a time to dive in and work before lunch. I think we'll get there earlier. So we may. Also like to mention, I guess the meeting to CDC today, but I do have to leave at get a flight at 3 o'clock. So I'm leaving here about 1 and have to leave the rest of the meeting. We didn't have time for the hospitality suites and everything, so I just asked her.
That was the reason he came and said that.
That's right. Anyway, so with that, if we're a little bit early, I hope Martha and Diane, they're not here. Ah, okay. Now. Okay. Well, I'd like them to bring up one particular item for us to talk about, and that is two, let me say that, but the topic is functioning of the committee. One is, I think, with all the material we got yesterday and the notes we took, there's going to have to be a process of synthesizing, which I think is something that takes some reflection and thought on all our parts. So my ask is, to the extent people would be willing to go through that, and then actually have a time when we can maybe speak or do some work to try and synthesize and see what we came out of it. More information that I could absorb in one day. So if people are willing to do some work between meetings, I think that would be very helpful. And the second thing is, it is extremely hard to create momentum when we meet once a year face-to-face and then have two line calls, which are much different, and they're usually one day. It's hard to do this for 2 days. I would like to propose that as a committee we formally request of Secretary, the Administrator, and David, our federal representative, that we have 4 meetings a year, and 3 of them are face-to-face. Other advisory FACA committees do that, including FACA committees to HRSA. So that would take more time for each of you away from your lives. So I think we should discuss that, ourselves. I picked that number. It could be any other number. But I think a strong recommendation from the committee would be important. I know that Dave and other HRSA staff have raised this issue before, and of course there's so many competing priorities with the budget and with time in a federal agency that it's hard to get those questions to the right decision level, but I think a formal request from the committee might be able to do that. Thoughts? I think
This is Vijaya. I support that recommendation.
I think it depends a lot, this is Paul Weiss, on how serious we're going to be about meeting our objectives, which would require a lot of work between meetings to justify increasing the number of meetings face-to-face. In other words, if we're going to have subcommittees that take on responsibility to do the work, it's going to be required for this committee to play a serious role in a contentious public discourse on these issues, then great, then let's meet more often. But if it's just meeting more often without doing the serious work that's required in between the meetings, then more hassle than it's worth and more than is efficient.
Steve Calvin here. I agree that meeting more frequently, if we are serious about doing this, it's a really good idea. And to answer Paul's request too, I'm willing to do that. I have, I'm at a point in my career when I can. I would ask too, so for David, so there are resources just logistically of putting things together, and so it isn't as if we're doing a lot of the things that could be done here. I don't know exactly what I'm asking for, but there are a lot of resources. I mean, the CDC and other, trying to bring all these pieces together, CMS, CDC, CMI, just pulling it together. If that's available, I'm all in.
This is Belinda, and I would agree. I do think we do need to make that decision now, though, if we're truly serious about it, because this will be a lot of work. And I think those of us around this table and on the phone, we are serious, but I think we need to be clear on what that commitment is. And we want to make sure, as we're making recommendations, that something will happen with them, that they don't end up on a shelf somewhere, that these are actionable recommendations that, folks around the table can take leadership in doing it because this is the work you do, but also partners and others. We want to make sure we're making the type of recommendations that are going to move the needle and not just make another set of recommendations that sits on a shelf. Because I'm not even 100% clear on what happened with the recommendations from 2013. Is there a process to know what happened in that set of recommendations? Because there were some really good recommendations, but I'm not sure we're clear on how they were utilized once the recommendations went up.
Others on the phone?
This is Magda. I think there's a creative tension here, as Paul articulated quite explicitly, in that I think there's no doubt of folks' commitment. I think what you're hearing reflected in this conversation is what was reported by Ed and the conversations with each one of us. So the idea that there should be right-sized gatherings and in person and or on the phone that keeps the momentum going, absolutely. I think structure is essential here. When we left a year ago, we had 3 different tasks that we said would be completed within a 6-month period. There were folks who stepped up to lead each of those tasks, one around membership, one around being able to glean the history, and one about being able to begin to frame a new narrative. And I think having that kind of structure and people who are willing to hold accountability for it with some clear deliverables within a specific period of time was extremely helpful in our being able to move forward. So I encourage us to pair this notion of periodicity of our meetings, how frequently we come, and being able to make the ask for more with a structure and an agreed upon set of deliverables with urgency and efficiency that will essentially warrant and justify more time together.
Thank you. Janelle, Jean?
Hi, it's Janelle. Can you hear me?
Yes, we can.
Okay, perfect. I agree. Women are dying every day, and we have an opportunity to change that, to affect that. So I am committed also to meeting more frequently, and I really embrace the idea of being able to meet locally. Magda has presented that a number of times, and it has been helpful when I've been able to meet with her one-on-one to go over different parts that we were working on with SACIM. So I would be in for it.
This is Tara Sanderlee. I also support increasing the amount of times that we meet. I think we just have to be careful that, not all of us are here at the table because of, other things. And so we just have to make sure that we increase the number of times that we're supposed to meet, but that doesn't just make it more difficult, that we still stay divided. I understand that it's difficult for everybody to make all the meetings, but I think we just have to be realistic what that means.
Thank you. So that doesn't only affect committee members, obviously. Our federal ex officios add so much to this meeting, and they're one of the reasons we like to come together to hear and get updates. So I don't know, Dr. Barfield, if you are willing to speak from your point of view about the utility of that and the ability of our federal ex officios to participate more frequently.
So,
Hi, this is Jean Connery.
so this is Wanda Barfield. Yeah, I think that Paul's point was really well taken in terms of thinking about what the purpose is going to be of the increased frequency of the meetings. And one thing that might be important to consider is at each meeting to say, okay, this is what we plan to do. When do we want to reconvene? And if it looks like the frequency is going to be increasing because of the work, that might be, a more practical way to approach it. From the, federal standpoint side, and I think it's the same for our other HHS colleagues, we're here to support the committee and to, be as helpful as possible. We may not be able to travel in person as frequently and can certainly participate on the phone, but, because we're in Atlanta, it's a little, it may be a little bit more challenging, but certainly we can participate by phone.
Good morning, this is Lee. From the agency's perspective, as I said yesterday, you have a unique opportunity here with the committee being rechartered and the visibility of the issue right now. The agency stands, as Dr. Barfield had said, to provide support services that are necessary for you to discharge your responsibilities and the commitment that you've made. I cannot at this point commit additional financial resources, although we would be happy to explore the added cost of convening additional time. I think one of the questions that we would have, and it's a larger question about the committee going forward, is whether you have established structures in place to ensure that you will use that time in a useful manner and that you have a clear strategy for how you'd like to proceed. There is a lot going on in the field right now on these specific issues. It is worthwhile, I think, for a committee with these responsibilities to engage with the various partners, collect that information, try to digest that information, and make recommendations to the Secretary, which is what your purpose is. And at that point, I throw it back to you as to the commitment that you're interested in making and how you will sort of ensure that that commitment is followed through in a way that justifies the expansion. So we're supportive of it. We welcome the recommendations, knowing full well that it is a political environment as well. So a couple people who are particularly vocal in a way that does not acknowledge that it's a FACA as opposed to just an advocacy group, I think could be difficult for the group as given its responsibilities and roles. So it does take some tempering. We do see tremendous opportunity and support it. So it is your recommendation that you're choosing to make, and we will support it and encourage it.
Can I ask a quick question? So, Lee, when you SACIM, Federal Advisory Committee. Oh, okay. Yeah, I'm just kind of a neophyte at it. So I understand. So what you're saying is that if this becomes something where a lot of sort of
fireworks are going off that are not productive, it would, I mean, I'm not even determining what that would be. So can you maybe just fill me in a little bit more about?
Sure. Fireworks, I think, are in the eye of the beholder, whether they're welcome or not. There is history of some federal advisory committees that have done very cutting-edge work and made significant recommendations that influence policy in the direction of the department's programs. As a FACA, though, there are rules by which you must sort of operate, which is why you go through background checks. We check on, you know, your financial engagements, those sorts of things. And we have certain responsibilities around representation, fair representation of all viewpoints. And that is one of the reasons why I'm calling you back to the structure of how will you operate this in maybe a more intensive sort of way. How will you ensure that it is a balanced representation of where you feel as an expert body the field should go and what those recommendations would be. Understanding the limitations and restrictions that the federal government has on some of these issues. So there are lots and lots of rules around FACAs. We work very diligently to comply with those requirements. And we're also mindful of the fact that there's an executive order right now that the President has put in place looking to decrease the number of FACAs. So that's bringing the big P into the discussion for political. But we would like to move forward. We would like to advance that agenda, knowing full well that committees are scrutinized as well for their, one, the use, and two, whether or not they're sticking to what their purpose is.
I think that was a very, very important set of comments. I really appreciate it. You know, it's so easy to say we have a bully pulpit. Let's get out there and say everything we want to say or something. But we do have a specific role. We are here as a federal entity and as temporary federal employees, which is why we had 15 pounds of paperwork. And so I think we do need to be cognizant of that role. And it reminds me a lot about AMCHIP or Castile Roy, where you need to speak in a way that people can hear you, being sensitive to triggers, being sensitive to how things are interpreted by different people. Our objective is to achieve improvements in maternal child health, not to start fireworks. And so I mean, obviously, if we feel strongly something has to be said, then it's a matter of how best to say that so we can be heard. And yes, we do have a responsibility to bring forth what we think has to be said, but very cautiously with the right language. And I know that's how we work in a very bipartisan way with ASTO, because as you imagine, with every 59 states and territories, we had Marx and Lenin on one side and Attila the Hun on the other side, and you had to come up with something that worked. Because likewise, the governors would have cut our funding, their membership funding, if we went too far. And I did get calls from the NGA and had to justify why we were doing certain things. So I think it's a really important statement to realize the context we're in, and be political in that sense of sensitive to how things are viewed by different groups and sides. The other thing I'll say is what I also hear from you is completely reasonable, is kind of give us a proposal to justify it. And so I think that if we do go forward to say this is something we want, it should be say, and therefore the committee will work to develop that proposal. Federal advisors. Belinda, please.
The other thing that we had talked about was expanding the size of the group. Right now, I'm not even sure how many members.
So we have 11 members, and we're allowed to have up to 21. So there's 10 vacancies.
So we know we have made recommendations and moved them forward, but is that those recommendations, is that like a 6-month process, or is there any way to figure that out? Because that also may, if we're waiting for other people to join us, it may help impact the frequency of our meetings as well, because we may be bringing in additional people with additional backgrounds and additional thought process. So
it is a very long process to bring folks onto one of these committees. There are many layers of review and approval, and then once even we have the approval of the names, then all of your fun work starts of getting on board. They have streamlined it quite a bit, Executive Secretary, and they are committed to doing it as quickly as possible, but there's certain steps just can't be skipped for sure or shortened. We do have the list of names that you all have moved forward to us. Dr. Ellinger presented it to me and Dr. Warren. We also are at the final stages of sending out a Federal Register notice so that the public has a chance to weigh in on other people who may want to join and get those names and a more broad representation, a broader pool of people. And then we will also send it out to, to networks and partners and have them send it out as widely as possible. So the process is, as the DFO, I come up with a list, then it is approved at a variety of different levels and can be changed at any one of those levels. And then finally, that list is final, and then the work of onboarding happens. So it just depends on how long each one of those steps take and how long each one of those people take to review. The same Office of the White House Liaison that approves a SACIM list also approves Supreme Court justices, right? So everything in between and everything in between. So it's the same, every political appointment type has to go through the same office. There are sometimes we get bumped, as you can imagine.
You're very important.
But we are committed at the Bureau to get the list moved as quickly as possible, understanding that, as we discussed yesterday, there are some definite gaps in representation that we would like to fill. And as Lee said, and as outlined in the charter, we are committed to making sure we have representation not just in perspective, but also in profession and geographic, and all the others, race, ethnicity, gender as well.
So can you share what those gaps are that you're looking for?
I think you all came up with
the list. I know
the list that you
prepared.
came up
okay,
with.
got it.
Yeah. So, and it's outlined in the charter too. So, I think clearly one of the things I've heard very, very loudly from you all as recently as yesterday is consumers.
So, I think we have our speakers in the room. So, for those listening in, sorry for the housekeeping, but I think it's very important. What I would like to ask the committee is for you to express your opinion on the notion of putting together this, on the notion that we would go to more frequent meetings, and I'm proposing 4, with 3 being face-to-face, and with the idea that we would then put that justification to support that together to submit to our federal representative. How about verbally?
Steve Calvin, I'm in.
I support it.
Hogan supported.
Yep.
Paul Rice.
This is Jean Connery. I cannot commit to 4 meetings a year.
This is Belinda. I support.
This is Magda. I think that what you said, Paul, was perhaps best said in not the specifics of 4, but more frequent commensurate to getting the work done. And I would just, in respect of Jeannie's comment just now, get a little read of what is reasonable. But I think there is serious commitment of all of us members. It should just be proportional to achieving our objectives.
Thank you. Did we hear from everybody? Janelle?
Yes, I agree. In working enough to get our work done, to drive forward ahead, and to feel proud of what we've done.
Yeah. Okay. As I said, I picked a number just to have something to react to. So otherwise, Ed would come back with 10 meetings.
Right.
Anyway, very good. Thank you. I'd like to move on then to our next group of speakers, which will be who will be talking about the fetal and infant child death review. We're fortunate to have Martha Firma here, who's the acting chief of the Healthy Start East Branch, Division of Healthy Start and Perinatal Services. Commander Sonia Furman is a senior public health analyst and the acting chief for the Healthy Start East Branch, where she provides strategic leadership for the day-to-day management of the National Healthy Start program and programmatic guidance to grantees under the Federal Healthy Start program. With her is Diane Pilkney, senior nurse consultant for the Division of Child, Adolescent, and Family Health at the Maternal Child Health Bureau. She has over 20 years of experience in public health at the local, state, and federal level, including the Centers for Disease Control and Prevention and the Washington State Department of Health. So thank you. We appreciate your being here and look forward to your presentation.
Good morning. Thank you so much for having us here. We were honored to be invited, and we believe that this is a very important topic that part of the advisory should have some information on. So, as they said, my name is Sonia Furman, and I'll be co-presenting with Diane Pilkey, and I won't give you the background because a small bio was just read out. Okay. So today's presentation objective, at the conclusion of this presentation, you will better understand how to explain HRSA's role in supporting infant fatality reviews, identify how the National Center for Fatality Review and Prevention partners nationally to achieve these priorities, and distinguish the differences and approaches on the infant review team, recognize the opportunities and provided by the case reviewing system. Now, HRSA MCHB supports fatality reviews. MCHB has been supporting fatality reviews since 1990. Initially, the Bureau supported technical assistance of fetal infant mortality reviews, or known as FEMR, through a cooperative agreement with ACOG. Then in 2002, we supported the development of a national center to provide technical assistance and training to child death review, or CDR, teams around the country. In 2018, we released a notice of funding opportunity, and both CDR and FEMR were awarded to the Michigan Public Health Institute. I'm sorry, Michigan Public Health Institute, yes. The National Center on Fatality Review and Prevention is funded support through the work of the National Center. I'm sorry, I keep going in and out. Sorry about that. Can you hear me better? Okay. Somebody should have said something. Okay, so the National Center for Fatality Review and Prevention is funded to support the work of the National Center for Fatality Review and Prevention in order to work with child death review teams and fetal infant mortality review teams to provide technical assistance and training to maintain a web-based reporting system for both CDR and FEMR in order to disseminate information and funding related to fetal, infant, and child death, and to facilitate the translation of team recommendations into actions and practices. What the ultimate goal is obviously to prevent fetal, infant, child, and adolescent death. Diane will now speak about the different types of fatality reviews.
I'm actually going to, for those in the room, I brought a couple examples of the case reporting forms for both FEMR and Child Death Review, as well as some of their guidelines they've created just to pass around. And for those of you not in the room, and at the end of this presentation, we'll show the website for the center so you can find that information. And I want to reiterate what Santi said. Thank you so much for inviting us. We're very excited to be here. So fatality review provides a unique opportunity to identify how systems work together, but also to highlight inequities in how people access and are treated by systems. There are many child fatality review programs, as you can see up here, and we're going to focus on child death review, or CDR, and fetal infant mortality review, or FEMR, and we're going to talk about the sort of similarities and differences between the programs. This slide shows the overlap. Let me know if you can't hear me. This slide shows the overlap between CDR and FEMR. Both of them review infant death, but FEMR also reviews fetal death and is more healthcare systems based and focuses on preventing deaths by improving maternal and infant health, prenatal care, clinical care. Whereas child death review reviews deaths of infants through adolescence. The upper age varies by state, and it tends to be more community-based and focused on improving systems and identifying global prevention strategies. Most communities do one or the other, but where they're doing both FEMR and CDR, one of the things that the center is working to improve collaboration between them. There's different models of how that's working or not working. But they created a guidance and they provide TA on how to enhance collaboration so they're not duplicating efforts. So I'm going to talk about child death review. And child death review, as does FEMR, represents an opportunity to turn tragedies into lessons that can be learned to prevent other deaths. It's a multidisciplinary process where professionals come together, they bring information to the review, and then the team looks at that information, talks about it, and identifies risk factors that contributed to the death. And they essentially painting a picture of that child's life and their death in order to try to find ways to prevent future death. Many states have advisory boards to move those recommendations that come out of these teams into action. So why CDR? As I said, it's intended to examine the circumstances around a child's death and life and provide insights into the gaps in services, systems, modifiable risk factors that you can't get from just looking at vital statistics, for example. It's not focused on blame or culpability. The idea is to hopefully address where the system may have failed in a non-blaming way so that future deaths can be prevented. This information from child death review can be used to inform planning, policies, quality improvement efforts, health systems developments, and enhance efforts to develop and maintain risk reduction and prevention programs. The data from fatality review are often used at the state level in the injury prevention programs, Title V, MCH programs, and others. And ultimately to be effective, information from the reviews needs to lead to recommendation and to action. And I think that's something in CDR in particular that many teams and communities struggle with. So CDR today, there's more than 1,300 local and state teams that the center works with. There's actually more CDR teams out there in all 50 states, DC, Guam, and some tribes, as well as the Department of Defense. These reviews occur at can either occur at the local and or state level. About a third are purely local, a third are purely state level, and the rest are a combination of the two. These teams usually have very limited funds and participation, and is voluntary, of course, and so resources are a challenge. All of these 1,350 teams that the center works with use the standardized case reporting form that I sent around an example of, and again, it'll be for those of you on the phone, the website at the end of the presentation can show you what that looks like. And then most of these teams are also using the free web-based case reporting system to enter data into, and I'll talk about that a little later. Although the form itself is quite long, the reason it's long is because it includes major causes of death. So for example, if you're reviewing a drowning death, you're going to include information, general information about the child and their family and the situation of the event, and then fill out the drowning section. So that's why it seems long, but it's not as long when you do it online. The multi-state CDR case reporting system has more than 200,000 child deaths entered into the system, including 106,000 infant deaths. And while the best practice is for CDRs to review all deaths, in reality that doesn't happen because of resource limitations primarily, or whatever the focus area is of those communities. So they often prioritize unexpected deaths, so deaths due to injury and violence, and then including child abuse, neglect, and then the SUID deaths. Information so the team members bring in information from their, whatever their focus area is, and they bring in information on the child, the family, the perpetrator where relevant, and the community, findings from the death scene investigation or autopsy, services accessed and services needed, risk factors associated with specific causes of death. They discuss and make recommendations, and then they also identify in the case reporting system where the factors that affected the quality of that review. Were they missing key team members? Were they missing key information? And was the death scene investigation, for example, inadequate? And these are the primary child death review team members, the pediatrician or other family health provider. And I just wanted to mention that the AAP has a child death review section, which has over 500 members, and they're trying to encourage pediatricians in particular to become members of their local child death review team. Public health, the medical examiner coroner, of course, law enforcement, child protective services, mental health, emergency medical services, and others, depending on the type of death. Now I'm going to turn it back over to Commander Furman, who's going to talk about FEMA.
So, thank you. So as we spoke about, the two different types of review. We're going to talk a little bit about the FEMA, the fetal infant mortality review. So what is the purpose of the fetal infant mortality review? It's when vital statistics, like Diane mentioned, cannot tell us the full stories. Communities turn to FEMA reviews to tell us how and why babies are dying. FEMA is a warning system that can describe the effects of the healthcare system and the changes in the systems. It's a method for implementing continuous quality improvement. It's a means to implement needs assessment, quality assurance, and policy development essential at the local level. Fetal infant mortality reviews has two goals. The first is to describe the social, economic, cultural, safety, health, and systems factors that contributed to the child's death. The second goal is to define and implement community-based action plans founded on the information obtained from these reviews in order to improve systems change. So why examine the fetal and infant deaths? They are key indicators of social, economic, civic, and environmental well-being, or lack of. Healthy communities nurture healthy women, infants, and families. So the goal of FEMA is to see what has happened, what systems need to be put in place in order for the community and to thrive. So the FEMA process, I'm just going to briefly describe the basics of the FEMA reviews process. Okay, so it's a multidisciplinary community team that examines fetal infant death cases. FEMA is a community-owned, action-oriented review process that reviews the deaths of infants in their community and make recommendations to spark systematic changes to prevent future similar deaths. So a little bit different than the CDR process, which we do look into making improvements, but FEMA, the ultimate goal of FEMA is to find out what happened and how to change that. FEMA cases that are reviewed are de-identified, so the names of the families, the physicians, the institutions are all confidential. FEMA is not focused on assigning blame. FEMA is focused on improving systems. One of the unique differences of some of the other reviews in the FEMA review is the maternal interview. The maternal interview gives the mother a voice into her own experience as to what contributed or how she is, what happened prior to this infant's death. And it's one of the few reviews that it's guided by the mother and it's her story. Maternal interviews, when done, yield a wealth of information. Maternal interviews help the team understand mother and family's experience of racism or other inequities in the community or in their state, and how these experiences have impacted maternal and child outcomes. The aim is always, when possible, to have a maternal interview. That is not always a possibility. There are various barriers to obtaining a maternal interview. Some of these include the challenges of locating the moms. Even in the states and communities that have FEMA reviews, cost is a factor. There's a lack of funds for enough staff to be able to go out and interview every mother. And the reality is that in some areas, even when there is that funding, the providers or the interviewers really feel uncomfortable with approaching a grieving mom and trying to get some information as to what happened. So it's almost similar like in hospitals when someone is toward the end of the death, and we all know how vital organ donations are, but it's always a discomfort with approaching someone who's grieving, who just had a death, to say, hey, by the way, can you help us? So 70% of the FEMA teams do attempt to get an interview. However, about half of them only obtain that. Again, sometimes this is the discomfort, and sometimes the families just do not want to speak about that. And I'll go into it a little bit more, but here's a general overview of the FEMA process. It's a two-tier approach. Now, from the beginning, the FEMA model strongly emphasizes the importance of community-based, and it's a two-tier process. And as you can see, there is the case review team and the community action team. It's purposely done because each team has a distinct function. The community review team has the role of reviewing the cases, like I spoke about earlier, and drafting recommendations, while the community action team, or as we lovingly call the CAT, helps to disseminate the findings, facilitate implementation, and recommend policies and intervention. At every step, the process is at the local level. If FEMA tries to maximize the confidentiality, all information, like I said before, from the medical records and the maternal interview is stored in a secure file. All identifying information, patients' names, providers, hospitals, everything that could possibly identify this family and, is removed. And in some of these communities, the families or the communities are very small. So even things as gender of the child that might not be that, 50% of us are either one or the other, sometimes that is also removed based on the size of the community, just to make sure that all information that can be related to identifying the child or the family is removed. No institution, provider, or family identifiers allowed in the case summaries. All female team members must sign a pledge of confidentiality, and which prohibits them from discussing any and all activities that are discussed within the team, and reviews themselves are close, obviously close to the public, and the review team members are protected and held harmless by state laws, so that in the event that something comes out of that, they're not required to report certain things. Okay. So here, this is a breakdown of the role of the case review team. So they, obviously, it's in the name, they review the cases. They look at the central event, which is usually, obviously, the death of the child. Look at trends. They also look at incidental findings, such as lack of medical care or culturally competent medical care. And they present present and contributing factors. So they look at some of the current and what could have contributed. And they develop initial recommendations. The CDR team is, and I will show you on the next slide, is a multidisciplinary team which represents the community. These meetings are usually held 1 to 2 hour closed meetings. In these meetings, they look at 3 to 5 cases, and the team usually consists of about 12 to 15 members on the average. Again, all the information that they hear is de-identified. They look at the issues, they look at if the interview is available, and then make recommendations based on their review and their findings. The review case teams looks to see and determines if gaps in services occurred, as of, like I mentioned earlier, no prenatal care or perhaps not culturally competent care. And they document what opportunities for improvement exist. Reviews the story, what happened to this baby from pregnancy until the time of death. Identifies the issues. Were the clinical, community, or health systems, did they have factors or were they part of it that contributed to the death of this child? And they make recommendations to professional groups as well as to the community action team. And this is where the second part of the review process comes. Once they have made and looked at the reviews and recommendations, then they pass it over to the review teams. And for example, some of these actually have immediate implication or changes how the community then looks at care for the woman. For example, one team reviewed cases where domestic violence was a significant factor. As a result of the care providers and the team, they agreed to begin screening all pregnant women for domestic abuse or domestic violence. So once the review is done, they make the recommendations, then the CAT comes in, or the Community Action Team. And their role is to develop creative solutions to improve services and resources for families based on the recommendations made by the review team. In addition, their goal is to enhance credibility and visibilities of the issues related to the women, the infants, and the families within the broader community. Again, to bring to light some of the issues that might have contributed to the death of the infant. And they do this through presentations, media events, written reports, and even some community policy changes. And continue a little bit some of the other roles that they have, which I talked a little bit. Work with the community to implement interventions to improve services and resources. Determine if the needs of the communities are changing over time. And that's very important. Just a little bit about me. I grew up in New York City, and for those who knows, New York is a 10-block radius is a total different community than another 10-block radius. So as people migrate and change from community to community, the community, what worked 5 years ago, might not work for this new community. So this is an important role that the CAT, or the Community Action Team, does, is to make sure that the services or what's in the community now is good for the community. And finally, they safeguard successful system changes from being discontinued in the future. And that's an important role of the CAT. And that's why it is very important that these FEMA team reviews and the CATs are from the community, because they have vested interest in the community to succeed. And if something is working, and we know sometimes budget cuts at the local community, some programs are cut or some funding is shifted. So the CAT is up there always making sure that what's working to continue it. And they had one of the examples, it's happening in one in Texas. Recently there was San Antonio, by the way, has a very large FEMA program. And with some changes of government, and the mayor or the governor was just changed about 3 years ago, and there were some systems that were in place that were on the chopping block. And one of our Healthy Start programs, which is very active in the San Antonio FEMA program, was able to rally up, and they kept one of the services that they had implemented. So that's definitely one of the pros of having community buy-in and community involvement. So, as I mentioned earlier, in 1990, MCHB started supporting the FEMA program. So what has happened since then? Well, we've grown a little bit. Most FEMA are local programs with the advantage of being identify community-specific determinants of health. FEMA today has a presence in 28 states, to include D.C., Puerto Rico, some tribal, and as well as the Northern Mariana Islands. Now, we do have not formal FEMAs as in Guam and some of the other Pacific islands. However, they do meet quarterly, and they do get support from the Northern Mariana Islands. So they're working on it, on being able to support it. Sometimes it's a matter of funding. It's very difficult to support a FEMA review team when there's not enough resources. And sometimes, especially with the Pacific Islands, it's very difficult to get all the specialties that would like in order to combine. There was a time that they were all meeting together in Hawaii, but then again, that became a little bit, the cost involved was a little difficult. Okay, so here you are. As you can see, the ones in pink are the ones that are currently having FEMA programs. And I just wanted to mention, because they're very proud of this. If you look at Indiana, which has 17, when prior to this latest funding opportunity, Indiana only had 7 FEMAs. And because of this new opportunity, we're now, they were able to help support and train 10 additional FEMA programs in Indiana. So it's slowly growing. We anticipate now, especially with the new Healthy Start, and some of the part of the Healthy Start requirement is that they have some form of review process, whether it be FEMA, PPR, or others. So I think that given that FEMA will, it probably looks like it's going to grow a little bit. Okay, so I talked a little bit earlier about some of the expertise or some of the members that compose the FEMA team. And as you can look at it, we have some medical experts, the usual peds and, of course, OBGYN and some others. And we have also health providers such as nurses, social worker, home care, and home visiting. We also involve the emergency medical personnel and human services providers such as welfare agencies, mental health, substance abuse. And we also partner with public partners such as WIC and Medicaid. And we try to engage the community leaders always, and advocacy groups to help support and spread the word. So Diane will speak a little bit right now about the other infant death review, but I'll come back afterwards if you have any questions, or if you have any questions now, I will be here. Thank you so much.
I think Sansi highlighted a couple of things that FEMR has that CDR does not have, which are really important. One is that maternal interview, and the other is that community action team that's associated with every single FEMR. And it prompted me to just mention that for child death review, the ability to move recommendations into actions has had varying success across the country. Some states actually mandate that the state produce a report every year to their legislature with the findings from their child death review and what the recommendations are and what actions were taken. And so it varies greatly by state to state, but every single program, and there's a CDR state coordinator in every state, you know, that's their main goal, is to try to drive this data into action. I wanted to talk a little bit about what components of effective infant death reviews. Part of the technical assistance the center provides for both FEMR and CDR is how do you implement effective reviews. And some of those common components are that there is a clear purpose that is understood by all and is focused on prevention, that reviews are coordinated and comprehensive, and good leadership is really key to this, both in terms of being able to organize and facilitate the review meeting, but also in understanding the context of the community. Having the key relevant partners at the table, which Santi mentioned, both at the review and when developing and implementing recommendations. And then using that data to identify those mitigatable risk factors as well as agency practices and policies and gaps in community services and systems. And again, the focus is on translating knowledge into action, which requires effective recommendations that can actually lead to improved systems and prevention. I wanted to mention that the CDR and FEMR infrastructure also offer the opportunity to address sentinel or emerging issues. For example, CDR teams typically review opioid-related deaths to children, but the team lead in many states also sits on the state's opiate fatality review teams that review adult deaths as well. Recently, there have been a renewed interest by tribes in implementing child death review in their communities. Typically, states, the community or state child death review team will review tribal deaths, however, with varied participation from tribe members. So these are tribes that want to actually implement their own tribal child fatality review programs. And so the center has been doing a lot of work this year with the Casey Family Programs on providing training and technical assistance. And then in 2016, around the time Zika was a big issue, the center and the CDC together produced a guidance on reviewing Zika-related fatalities. This was also used by some of the teams to look at non-fatalities as well. And then the FEMR methodology in particular has been used by some programs to review other MCH sentinel events such as, and this often focuses on morbidity, not necessarily, not limited to mortality. So such as the FEMR fetal alcohol syndrome, congenital syphilis, FEMR HIV, and preterm low birth weight birth. I also want this, I have a picture here of the guidance on the Zika-related fatality review, but I wanted to mention they produced several guidelines which are on their website, relevant to both FEMR and CDR. Most recently, one on improving racial equity in fatality review, guidance for teams in addressing vicarious trauma, given how hard it is to review these fetal and infant deaths, and guidance for effective reviews, guidance on child maltreatment reviews, the role of fatality review after disasters, which they did with the CDC as well. And they're working on one on collaboration with tribes as well as one on suicide this next year. So I want to talk briefly about the case reporting system that we talked about. So it's based on that standardized data form, the FEMR and the CDR one that I passed around. The CDR teams have been using it since 2005, and it includes many of the same data elements that are covered in FEMR. But in 2018, the center added an additional FEMR-specific module to collect data and that includes collecting data from the maternal interview. The case reporting system is also used by the CDC's SUID registry grantees and the National Institutes of Health, CDC, sudden death in young grantees. And both agencies have provided and are providing some funding to the center to enhance data collection for those states that they're providing grants to, although those data elements are available to any team that wants to use them, whether they receive the grants or not. As I said earlier, there's more than 200,000 deaths in the case reporting system. There's more now. That was from February. And about half of those are infant deaths, and about a third of those are SUID deaths. There is a separate researcher database that states can authorize adding their data into, so that has about 129,000 of those deaths, of which half are infants. So essentially, the data, the teams enter into a data sharing agreement with the National Center, and those data are considered to belong to the teams. The major limitation of these data is that not all deaths are reviewed, and for various reasons, but it does capture some rich data that is not available in death certificates. So these are the states that are using the national, the case reporting system. There's 45 states, and they're hoping to come on board. As I said, each state does a data sharing agreement with the center, and those data are considered to belong to that state or local community. Those using the case reporting system have access to, I think it's 24 standardized reports where they can just push buttons and get reports spit out, but they can also add state-specific questions, which many have, and they also have the ability to work with their vital stats folks to upload vital stats data directly into the system so they don't have to enter that manually. And they can also download their data if they want to do some additional analyses. These are the FEMR states using the case reporting system. There are 56 sites in 17 states currently using it. The FEMR-specific module was rolled out almost 2 years ago, and so one of the goals of the grant cycle this year is to get additional FEMR programs to start using the system. And currently, there are 4,939 FEMR cases entered into the system. Information on this, I talk about information on the data form and data system are available on the website, but I wanted to also say that the center has created some infographics on their website as well related to child abuse, neglect, fire deaths, and opioid-related deaths, and they're working on others. In addition, we're exploring venues to get the summary aggregate data more publicly available. In addition, researchers can apply to use the researcher database. There's a data dissemination committee that reviews those applications, and often they go back for more to be resubmitted again. And as I said, this is a subset of the total database, so it's about 129,000 deaths. More than 21 peer-reviewed publications have been published, including one that was just accepted yesterday on U-shaped pillows and sleep-related infant deaths, accepted to the Maternal Child Health Journal. So we're excited about that when we use the data. So I just wanted to present a couple of snippets of data to whet your appetite. But if you're interested in more detailed data, the center would be happy to come and present data from their system, both the FEMA and CDR system. So these are, again, from the researcher database. So 43% of the infant deaths in there were low birth weight, 19% preterm. For 26%, there were maternal medical complications. 6% the mother had no prenatal care, and another 17% they had prenatal care at the 5th month or later. These are from the SUID deaths in there, and I think that I said there's about 32,000. So for those SUID deaths in the system, 16% were low birth weight. Most were found to be sleeping on an adult bed, chair, or couch. Only 27% were found to be on their back, although there's a fair amount of missing unknowns for that, and more than half were not sleeping alone. And I just wanted to mention, because it's an important topic right now, that a few of the data from around drug exposure, about 3% of the infants were born with exposure to some illicit drug, and for less than 1% it was reported that the mother drank heavily during the pregnancy. The reporting by teams of these deceased infants being born drug exposed has doubled since 2005, from 1.8% to 4.3% in 2015. The latest version of the data form, which was started in 2017, has a checkbox to collect information about what was the drug exposure at birth. And then looking at the poisoning death for infants in the system, 19% were associated with a prescription opioid, 8% methadone, and then 1% other or unspecified opiate. I don't know if we know that information.
Okay.
But that would be a good thing we could get them to talk more about if they come and if you're interested in hearing the data, which we'd love to present. You can get more information on the National Center for Fatality Review Prevention at this website, and including whether or not that your community has a CDR or FEMA program. And just thank you for the opportunity to come and talk about the work that these teams are doing. We're very excited to support, to provide technical support to them through the Resource Center, and we're happy to take questions.
Well, I have so many, but I think I'll just start with one. I'll come in maybe later. My first one is that it was a very good presentation. Thank you. I noticed that, obviously not all the states have these wonderful FEMA programs, right? Is it possible that, is there any cross-state support, between these states? Is there an interstate communication happening so that maybe if there's a FEMA group right on the border of, North Carolina or something, they can go across. So can you talk a little bit more about that?
Yes. Yes to that answer. We right now have some, like with Indiana, it's working with Minnesota, so we're working on pairing up some of these teams. We have a great TA project director, Rosemary Fournier, and she holds monthly and quarterly calls with the Northeast region, with Central, North, South, Central. I mean, it's about 6 of them. So there's always that constant collaboration, and so we have teams, especially in small communities that cannot afford their own FEMA programs. They do work with another state. In particular, also the tribal. Some of our tribes are across states. Wyoming and Wisconsin, they work together, and some other ones. So that collaboration, given the limited resources, that collaboration is not only important, but it's, to some of these FEMA programs, it's a necessity because they don't have the resources to have a full standing FEMA for each community or each state.
Hi. This is Dr. Wanda Barfield. First of all, I just want to commend you on your work and the collaboration that you have done with CDC and NICHD. I think, this is a really great example of, sort of long-term collaboration to really help to reduce infant death. I did have a question about some of the issues you raised with regard to fetal death surveillance. And I wanted to know if, what are some of the inherent challenges, particularly with some of the fetal deaths and some of the earlier fetal deaths in terms of perhaps the burden to the committees, because often there may be many, but yet relatively little information. And I also wanted to share that CDC is doing a pilot project using the PRAM survey to ask women questions around their experiences on stillbirth. It's been piloted in Utah, and we're hoping that in the upcoming funding cycle that we'll be able to identify other states that might be interested in this type of surveillance.
So I'm trying to capture your question here. So I know that we are working identifying some of the challenges with surveillance, some of these deaths is the lack of resources at this time. So it's great to hear that CDC is working on some of these issues. Will that be something that will be spread out to other states as well?
So, well, with regard to the FEMA review, I think sometimes the challenge is that, and I think you pointed it out, that there isn't enough resources to really help in terms of trying to review these deaths, even though they may be relatively large in number. With regard to the surveillance, I think what we will learn, particularly from Utah, is, and we actually did a pilot project as well, is that there is a way to sort of compassionately approach women who've experienced a stillbirth, that just like in pregnancy, they do want to share their story. We just have to think about, what is the most thoughtful, culturally appropriate, and sensitive way to ask women about, an important yet tragic experience.
Now, with our cooperative agreement, we do provide training and technical assistance to those FEMA review programs that would like it, because that is an uncomfortable situation. Providers or interviewers are just not comfortable with asking a grieving parent, a grieving mother about it. So we do provide training and technical assistance, and our goal is, and in their website, and if you look at also at the website, there are some tools that are provided so that even if they don't seek out the center to come in and to provide technical assistance, there are tools on the website to deal with this. But this is a challenge that it's very hard to overcome. But we are looking at providing, but I'd be definitely interested to find out what the results are of the Utah research, because that would help us.
And then another thing, and I don't know if it's being used by many states, but one experience that Alaska actually had was they were actually using some of their PRAM survey data for infant death. So they would, in addition to sort of doing the review, they would also, ask this, of course, internally, if that woman had actually been a PRAM survey participant. That way they could get a lot of demographic and behavioral information that may have also helped to reduce the burden on the interview.
Now, another thing that they're doing, and again, because for FEMA, that maternal interview really is it really does provide so much information as to the experience of what happened. Sometimes when the mother is not able to or not willing to provide that interview, sometimes a mother, a sister, or someone who's intimately aware of what happened, where the mother is not able to, sometimes our interviews come from a family member. We definitely always try to get from the mother, but sometimes they're just not at the right time. And some of the discussion, and I was sat on the last quarterly call, and some of the discussion which some of the FEMA review teams struggle with is when to approach the mother. Is it at 30 days? Is it at 60? So balancing, trying to get the information as vividly and as early on so that some of these details are captured versus the intrusion and when to wait. So this is a constant struggle that they discuss on a monthly and quarterly basis as how to best achieve that interview.
Belinda Pettiford, thank you all so much for your presentation. And I was reviewing your map. Unfortunately, I'm in one of those states that didn't have FEMA yet in North Carolina. So we've been meeting with Rosemary and trying to get legislation.
Yes, actually, I did speak with Rosemary. She's on vacation this week, but I spoke with her last week, and she was very excited that North Carolina is coming on board.
We're working on it. We'll see.
Thank you.
But on your map, you list, you know, like California has 16 programs, Texas has 3. So is any of the states actually doing it statewide? Because it seems like that makes me think they're just doing it in certain communities. And you may or may not know. And then my follow-up question to that is, I know Healthy Start has the opportunity to use some of their funding for FEMA, but you know other funding sources that states are using for their FEMA program?
I'm sorry, no, I do not know what the other sources are available, but that's a good thing to look at. There are some states, some FEMA programs, especially the larger states, you'll be surprised to find out that they have smaller amount of FEMAs, but it's a more, like for instance, and I mentioned this one in particular because I had the opportunity to sit on one of their FEMA reviews, Texas, and if you look at in the map, how many does Texas have? 3. And Texas is obviously a very, very large state. But the one that's centralized in San Antonio, that's practically half the state. And in that one, they also have the CDR, and they involve the military in there as well. So some of the larger states, although it doesn't make sense that they have less FEMA, they actually have a more comprehensive FEMA versus states like Indiana, which I just said started 10 new programs. But these are small local community programs, which eventually, I think as they progress, some of them might join and combine into a bigger review process.
Around that state versus local. I think, and that's always a big challenge, and sometimes it's resource driven, whether if you can't do statewide, or you can only do local, you can only do statewide. But I think one of the advantages of doing it at the community level is then you're looking at what's happening in your community, and you know your community, and you have that community context. And a lot of times what happens with child death review is where people are doing both. So they'll do those community ones and look at the issues in their community, but then at the state level, look at that same information or do reviews at the state level to see if there are bigger, broader issues across the state that they can do to drive prevention. So I think I kind of feel like in the state level, in some ways you lose that knowledge of what the context is within each individual community. But it definitely plays a role. And maybe that's a good role when there's a small number of deaths, for example. But Montana has a lot of both CDR and FEMA teams, interestingly enough, for a state that has a small population.
Why don't we go to the last question for Jaya?
Yes, thank you for your presentation. I was curious to have a little more information about the community advisory teams or community action teams.
The community action team?
Yeah, can you talk a little bit more about what the composition is of that team, and also how do you analyze the social contextual data? So are there specific reports that look at that information? How is that process?
So the community action team, it's community leaders, it could be community providers, it could be moms, it could be anybody who has invested in the community. So we have a lot of policymakers because part of the role of the community action team is to advocate, is to make those changes. So we have people within the community that are in a position to make those changes. Each community is different. So in one community, it might be the local city council. In the tribes, it could be the leader of the tribe. So there is not one set rule for the community action team. That is just based on the community and the leaders within the community and the advocates within the community. Unlike the CRT, the review teams, they have specific, or they get different disciplines, like I said, medical, social, community, WIC, those kind of things. Now, would you repeat your second part of the question? And I'm sorry.
So the second part had to do with how the social and contextual environmental data is analyzed, because I was looking at the case reporting system data that you collect, and sprinkled about there is some environmental and social information that is collected, but I'm wondering how you analyze that, because if we're interested in social determinants, I'm wondering how you get from this data collection to recommendations about social change, environmental change, or institutional change, et cetera.
That's the role of the community action team. They take that information. Again, it's kind of difficult to put it all as one set rule because each community is so different, but that's where the information comes from that drives the changes. So the community action team is the one that looks at some of that information, that looks at systems and looks at ways to improve it. So there is not one particular way because it's based on each community.
Mm-hmm. Do you have a specific example of just sort of help us follow the thread of how the data from this resulted in systems change or policy change?
Yeah, I mean, like the one that I brought up, some of the death of a child and some other issues, when they looked at some of the events that might have contributed to this child death, one of them, they started noticing that some of them had domestic violence and some had some issues related to domestic violence. So they took that information based on several reviews, and they actually made a systems change in that community that now hospitals, social workers, clinics, they all include now a tool on domestic violence and intimate partner violence. So that's one small example as to how something that has been occurring that they identified were some factors involved in some of the infants' deaths, and they made a policy change within the entire community.
Could we go to the committee members on the phone? Any questions there? We are running over time, but I want to give you a chance.
Yeah, this is Jean Connery. I just wanted to commend you on a fabulous overview and really providing a lot of information and insight over a long period of time. I mean, that it's with the amount of analysis and everything, it's impressive. My question actually is, are there any states or regions where we can look and say we've implemented FEMA, we've been able to review implemented changes and seen reduction in infant mortality? Are there any states or regions of the United States that we can point to, or are there other things like what we heard yesterday from the CDC with the maternal mortality review that we can now look at certain states where there's been a reduction? Are we seeing that?
I don't want to misspeak on that. I can get back with you on that. I will check back. David, the information, once I find it, okay. Yes, so I have an idea. I don't want to give wrong numbers, so let me get back with you on that, and I will let Captain De La Cruz know, and he can follow up with that information.
Thank you.
And
Go ahead.
I'm just going to ask a question, but not, this is Magda Peck, not expect a full answer. I'm just reflecting on the Maria presentation yesterday, FEMA today, child death review today, and other sentinel health event methodologies that are out there. And I just, for future consideration about an opportunity through the lens of maternal health in particular, how are we integrating across all of these yeoman efforts to have a much more consolidated both result that will allow us to be actionable. So I'm just looking for the integration across systems and for a future conversation.
Yeah, Magda, I agree, and that's what I was thinking also was about perhaps synergy, but at least at the data level, could that data be integrated in some way, which requires some data standardization. But there's a lot of rich data here and perhaps even overlapping systems. And I'd be curious about even what's the vision for the future about how this will all come together between the CDC system and your system and probably NIH, some of that work done there.
Thank you.
So I don't think there's a comprehensive answer to that right now. I know that there are efforts across the agency to coordinate on one of the things that I can point to that's been a direct action on our part over the last few years has been to bring together the CDR programs and the data collection tools so that just the programs that we have within one row are at some way being coordinated and shared. It does create complications for us because a lot of these are very organically developed groups that are working at the community or local level to collect the information. This is not my area of expertise other than the fact that we've worked on the CDR FEMA merger, and I know that we welcome opportunities to try to coordinate this. As Santi said earlier, this is a complicated process to collect the information. What is the right information, and how many times are we touching a person for one set of surveys and then another set of surveys? So we're trying to be sensitive to that in the design that we're using, all on a shoestring because neither of these programs are funded in a robust manner. So any recommendations that you could make to us would be certainly welcome.
Thank you. Yeah, this one does start to sound like a recommendation, also with the CDC programs.
And I wanted to add too that what I think what's happened over the last couple of years in bringing CDR and FEMA together, we competed them separately this last time, but they ended up at the same center. They worked really collaboratively together. The CDR director and the FEMA director both have experience with CDR and FEMA. They work really well together where people are interested in doing both. They help them coordinate that so they're not duplicating efforts and increase efficiencies and improve the review process itself. And I'm particularly excited about the data, the FEMA data being in this case reporting system as well, because before, as you probably know, there were systems out there like Bassinet, and they were all very individually based. Now we'll be able to do what we're doing with FEMA, what we're doing with CDR, and be able to look at a bigger, broader picture across the nation. So I think there's a lot of excitement to come. And
so yeah, and that's I believe Maria is going through a similar process. So there may be developing systems so they're interoperable in some way. We do probably need to turn on because we are behind, unfortunately, on our public comment period, which was at 10:30. So, David, I'm assuming that's something that you will be running. So, thank you. Appreciate it. Thank you so much for the excellent presentation.
So SACIM has a long history of wanting and encouraging input and guidance and support from the public. We have a very formal process in collecting that information, but which includes, submitting it in writing to me by a certain time so that we can make sure it gets into the public record. However, especially since we did not receive anything formal this time, at the chair's discretion, we have also just opened it up, which you have done throughout the past day and a half, and encouraged the public to speak and provide their input. We did want to make it more formal so that if you could not attend, you could still inform the committee. No one did that, but if you wish, you're welcome to open the lines and take any other comments.
Yeah. So, operator, is that something while you're getting our coffee, you could?
Yes, it is. So, as a reminder, anyone who's on the telephone, please press star then 1 if you have questions or comments, and we'll announce your name as we open your line. One moment, please, for any response.
I'm sorry. Yeah, absolutely. Yeah, please. So just make sure you introduce yourself and who you're representing, so we capture that in the notes.
Sure, thank you. Hi, Carolyn Sample, Director of Programs at the Association of Maternal Child Health Programs, or AMCHIP. And I wanted to express our excitement on behalf of the association around the support and inclusion of maternal mortality and morbidity prevention in the charter for SACIM. Is very exciting for us, and it feels like a wonderful opportunity here. And so one thing that we wanted to offer as some food for thought as you think about how to incorporate maternal mortality and morbidity prevention is that strategies that focus on maternal mortality often don't always focus on improving maternal wellness and well-being, health. And so we often focus on what keeps women from dying, not what helps women to thrive. And so as you think about your strategies, we think of thriving as being a critical bridge to improvements in birth outcomes for infant health and family health. And so not to lose sight of that when we focus on preventing death. So focusing on the health of parent, baby, and family and community, we're starting to think of this not just as a mother-baby or a parent-baby dyad, but a triad, including the family and community in that concept. And so we hope to model this in our new strategic plan, which came out in this year in 2019 and goes through 2021 with a goal called Chasing Zero, where we're driving down maternal and infant death and really incorporating being evidence-driven, so supporting maternal mortality and FEMUR as key strategies for understanding what's happening and equipping our members to act on those strategies, and to be evidence-driven and elevating what's happening in the field that's working, but also to be equity and women-centered. And so we're looking to promote women-centered, community-driven, respectful, and equitable care, and to support thriving by supporting and defending programs and policies that reinforce the mom-baby dyad and incorporating that family and community focus to thrive. And then I wanted to offer to the committee the opportunity to share at perhaps a future time some of the work and progress that's being made with 13 states in the Infant Mortality Coin, the Collaborative Improvement and Innovation Network around social determinants of health, which might offer some insight into some of the strategies that we think are working and would be helpful to scale up. Thank you.
Thank you. Anyone on the phone who would like to make a statement? I believe yesterday we had about 80 lines open.
Thank you for asking. I actually have no requests over the telephone lines at this time.
Okay, well, thank you very much. And so we had a lot of good information delivered that we can digest. We now have time on the agenda for a break. If we could take a 15-minute break and be back around 11 o'clock. Okay, thank you. The whiteboard in the room and have you see it. I think we have it figured out. Are we ready to go? Okay. Well, we're in good hands, and they're logging in. So, so this might be a moment where committee members thought would be we would go around more initially in a brainstorming process to get the ideas out there. Brainstorming, of course, means an idea goes up without evaluation. Back on it, somebody can add to it if it stimulates their thought, or add another item related to it. But the important thing here is that it's a creative process and not one that we cut someone down on. In fact, we may find out that odd idea is the best idea we have. Here we go. Also, David, did you want to update people on the community input?
Oh, yes. Thank you. So Latia, who was supposed to speak with us yesterday, we were able to reschedule her to 1:45 right after Ms. Joseph's presentation. And then that will be followed by a community member that Dr. Calvin identified, who was instrumental, or I'm not, well, part of, yeah. So we'll have two this afternoon right after Jenny Joseph. So it's going to be a nice block of time where we hear more from the people who are directly affected and directly dealing with some of the issues that we're talking about.
Right.
Yeah, I'm looking them up. I'm sorry. That's exactly what I was doing. I made the mistake of filing it away. So we have Latia from yesterday, and then Diana Jollies. And can you give a little background about?
Mike. Diana Jollies, Steve Calvin here. Diana Jollies is a certified nurse midwife, PhD, researcher, actively practicing midwife. She started her career at Holy Family Birth Center way down in Texas, which management is really good. Anyway, so she has a particular point to make about the Strong Start study results.
And then Latia is the one from Delta Health Alliance.
Right. You're on the spot there, David.
Stand by. Sorry, Latia Davis from the Delta Health Alliance.
Yeah, Mississippi or Louisiana? Almost there. Okay, we're ready. So Julianne and Vanessa are going to be driving for us here as we speak. And if they give me the nod, we'll get started. And they'll be capturing the ideas. So my thought would be we would go around the room and then folks on the phone. And I think we still have Janelle, Magda, and Jean on the phone.
That is correct.
Okay, so we'll go in that order then. Right. So again, the idea was to come up with those urgent, opportunistic ideas that we could put forth. Right now, we're not evaluating; we're getting them out there, and then you'll have time when Bob is leading you this afternoon to discuss more about what you want to prioritize among them. So, Steve, are you willing to kick it off?
Steve Calvin here. What I thought, I put together, I was just writing throughout the morning, and so you kind of want just a general.
More pithy if we can, so we can capture it.
Yeah. Yep. So you just
and just one idea, and we'll get back to the rest.
Okay. Yeah. Yep. So I just wrote out, to address the crisis of maternal morbidity and mortality, prematurity, and health outcome disparities, the committee recommends that within a certain period of time, the Secretary actively implement and encourage the proven beneficial care model identified by the 2018 results of the CMMI Strong Start study. Tried to make it that.
Okay, so actively implementing.
Sure. So to address, sure. Yeah, and I can even maybe,
Yeah, why don't you look up there and then you can see what
there we go. Okay. To address, to address the crisis of maternal morbidity and mortality.
How about if we assume that preamble is part of all this?
It is. It should be. You're right. Okay. So, good point. So SACIM recommends that within 1 year, the Secretary actively implement and encourage the proven beneficial care model identified by the 2018 results of the CMMI Strong Start study.
Great. Sarah?
I think my recommendation right now, like I said, I'm still gathering and processing all the information that we received, but I think the one thing that is the common denominator that's going on in my head is that there needs to be standardization and coordination between standardization, I think, within some of these things that we heard about yesterday. One thought that I had, like, for example, standardization between states. So when we heard about the MMRCs through the CDC, I think there's some incredible information that's going to be coming out of that. But in talking to Charlene, I believe is her name, afterwards, it became clear that each state is going to decide kind of how they're going to process that information and kind of what deaths they're going to include. So I think that one of the things that needs to happen is there needs to be more standardization across the board within states of how to make that data available, which data will be available. And then I also think coordination just between these organizations so that we can maximize all the incredible efforts that have been made and really see benefit and increase survivability in these infants and decrease maternal mortality.
I was working on it for an hour.
I think it's a good enough standard we're going to because we'll be able to work. Okay, Vijaya?
Okay, so this is going to be rambling. I'm going to warn you. So people in the health sector, their realm of influence is the health sector. So we need to get at conditions beyond the health sector that impact health. I mean, you know, transportation and criminal justice and all those other organizations and agencies outside of health. And I think the health sector, and specifically MCHB and HRSA, can play a role in changing government narratives, cultures, processes around that intersectoral engagement and play a role in disseminating downline to state and local government that structure and the reason for that, the importance of that. So I think SACIM could develop the language for a rationale for health policies, health equity and health policies, a business case, why health is important to transportation or to some of these other sectors, and disseminate some structure for how they can do it more effectively. Because if we don't move to that level of function, we're just going to keep spinning our wheels. Same results that we're getting now.
Following the federal government, making sure that their approach is an integration and also also pass down to state and locals. That you don't have to have four coffee pots next to each other, depending on which grant it is. Paul?
Thanks. This is Paul Wise. My general cut on this is really to focus on three principles, particularly in the hope of guiding a proposed strategy that would give us some structure for moving forward over the next year. The first is a focus on equity. The parallel declines in infant mortality rates over time really suggest that things that drive rates down can drive them apart. That we're not going to get at equity questions merely by looking at what's good or bad for maternal health per se. So equity needs to be not complete but central. The second is we look for fundamental discontinuities of grave consequence. In other words, that there are enormous number of programs within HRSA, we've heard a lot about it, but there are discontinuities that are generating the kinds of problems that we need to confront. For example, in the financial arena, the discontinuities is that the giant program that we've hardly talked about is CMS and Medicaid. We need to get Medicaid, CMS to focus far more than they have on the challenges, the programs, and the opportunities being discussed within this group. Strong Start is a start, but it's minuscule compared to CMMI programs and certainly what's needed in this direction. As I mentioned yesterday, the big tilt, the sucking of resources within CMS throughout the federal government is not towards this arena of concern. We have an enormous opportunity to get CMS and others. The Federal Reserve Bank is very interested in this, but it's not connected to the kinds of programs we've been talking about. We have these opportunities. The third principle that I would suggest is to take risk. This world has been very risk averse because it's been a hunkered down arena for the last 20 years. We need new strategies to take advantage of enormous new opportunities, but also changes in the epidemiology of risk and bad outcomes. And so equity, these discontinuities that are staring us in the face, but we're afraid to take risks, to have room and argue for experimentation within the SACIM arena of operations in ways that we haven't before.
Thank you, Phil. I'll try and formulate and talk at the same time. I think a statement about the centrality of the mother-baby dyad is an important one to make in almost in a all policies way. So both the work we do in the Maternal Child Health Committee, integrating that as much as possible. So we're looking at the mother-baby dyad, given the obviously mutual relationships there. But in all policies we look at, as we heard yesterday about in the criminal justice corrections area, a focus on keeping mother-baby dyad together, except when there's a risk of harm, clear risk of imminent harm, or something, wrapping programs around it, which would be in the human services. Sure that they are focused on wrapping around the mom, baby, keeping them together. And I'm sure there's many other areas also we need to think of. But I think we're perhaps missing that in all approaches. So, thanks.
Belinda Pettiford. I'm torn here because I do think that if we don't address equity, we're not going to see the improvements that we keep talking about we want to see. And I think that takes for us to be courageous, we have to be brave, and we have to put it out there. And I think if we don't say it, people assume we're okay with it not occurring. So I do think we have to look at health equity in our policies and health in our policies. My only, I have multiple concerns. And one is I do think, we want to make sure that we're focusing on, we have a connection with CMS, and we're working to make sure that everyone has access to care. And I think we tend to focus on the mom-baby dyad, but I always remember there's a dad there, and you don't want to leave him out of the picture. So I think when we do mom-baby dyad and we just talk about mom-baby dyad, we assume there's no dad. And I don't want us to forget that dad is part of this picture, so I think it's more of a family conversation and making sure that they all have access to care. But I also know from some of the early work around preconception health, when we were really focusing and trying to make sure we focused on women's wellness, the concern was if you focus just on women's wellness, the disparity ratio will get wider because the low-hanging fruit will be the women that get access to care, may not be the women of color that may not get that access. So I do have concerns about that. But I do think in crafting the dialogue that Ajay is talking about around health in our policies and health equity in our policies, I think if we craft that dialogue, I think we come out with at least one example of how to show that it can work. So I think in doing that, that if we select, we craft the language, but if we select that in working with CMS and others that we want housing at the table, then we pull housing and we really focus on what we can do to work to improve that. If we want it to be criminal justice, we select them. I think trying to select all of them will be so large that we may not get to any work. And that's what my concern is, that we actually do something that is tangible.
Okay, thanks. And remember, we'll go around multiple times, so we don't have to,
So this is Wanda Barford. I'm kind of inspired by what Belinda said and maybe want to add a practical example. So one area is the issue of, post-neonatal mortality, particularly around fluid and safe sleep, right? This is something we've struggled with for a while. There are, where are the opportunities to sort of reframe the practice of safe sleep similar to what we do with car seat safety, so that, within a hospital, and there are quality improvement projects that are trying to focus on this, within the hospital, really starting with the teaching and training of safe sleep position to families as they go home. But where are the other community safeguards that would allow that to be, supported and reassured? In terms of trying to address health equity, I think, in addition, we have to be very sort of thoughtful and specific about how that can occur, right? So we talk about it, but the big question, again, I mentioned this yesterday, is, what is the how in terms of focusing on what are the drivers of the disparities and then how do we address it? So going back to the example of safe sleep, we know that there are these differences, as demonstrated by PRAMS and other surveys in terms of safe sleep environments. So how can we strategically address those issues for different race, ethnic groups in a way that can make the change?
Okay, so let's go on to Janelle, and there's going to be plenty of opportunity to talk more in depth, and right now we just want to get ideas out there. So, Janelle? You may be on mute, or you may be delivering a baby.
Probably the latter.
Okay, Magda, and we'll come back to Janelle.
Okay. Let me not repeat what's already been said in the interest of time, but thank my colleagues for putting important frames and issues on the table. And perhaps premature relative to this afternoon's conversation, an immediate opportunity within the context of Medicaid and reimbursement is to look for the adequate coverage of doula, community health worker, and other extended and essential parts and people in the growing workforce that will, in the short run, add a buffer around some of the drivers of maternal and infant mortality. So this notion about that I hear on the ground is we want to be able to expand our doula program. We know that community health workers work. We have this interface, but who's going to pay for it? And if we believe in it, then we should push hard to ensure that that coverage is there, at least in the public sector. So that's one, public sector coverage of doula, community health worker, and other women-centered forms of care.
Thank you.
I'll come around for a second next time around.
Okay, thank you. Jean?
Oops, sorry. Let me get my notes out. First of all, just a great summary with all the principles that I think we need to follow, especially with the SACIM summary that we had, and then from the CDC, the March of Dimes, PREMI, the fetal infant death reviews. I think for me the number one issue is learning from where we're doing well, learning from any state, any city, any location where we're looking at drops or decreases in infant and or maternal mortality and morbidity is the number one learning step. And number two is the United Nations has identified 17 Sustainable Development Goals, the SDGs. Every country in the world is focusing on the SDGs for the next 11 years. Inasmuch as we can tie our goals and our beliefs to these SDGs, I think it's more powerful for us. For example, goal number 1, no poverty. Goal number 3 is health and well-being. Goal number 5 is gender empowerment, gender equality. So you can go look at the SDGs, and they're extremely broad, but they hit everything from poverty to universal health care.
Thank you.
And that's what it's going to take.
Thank you.
It takes universal access to health care.
Janelle, are you back? Okay, then Steve, we're back to you.
So is it worthwhile? What I did was I put some specifics into what I...
Yeah, I think typically the way this is done is like short, pithy ideas,
yeah.
And then we come back and discuss them.
Okay, so the specific recommendations, I guess one is just require each state Medicaid director to ensure that mothers in their state have access to Strong Start compatible care within 2 years, because Strong Start directly addresses the health equity outcome stuff. I mean, I think that later this afternoon we'll hear from Diane Jollis about that. So that would just be another.
Right. Thank you. Tara? Take it up.
I think something that we need to think about very carefully is that when we start thinking about infant mortality is, when I talked to the women that were here about FEMUR, they said that when I talked to them about what was included in those deaths that they were analyzing, it kind of gets back to my previous point. There's not real clear consistency across the board between these different FEMURs. Whether it's going to be, whether it's going to be a viability when that death occurred, when the death occurred maybe at 8 weeks and included ectopic or miscarriage. I think to get a really well-rounded picture of what infant mortality means, we need to have a very clear understanding of what's being included in these deaths that are being analyzed and at what stages of, when did fetal loss occur. For standardization of the data questions, I think it's really unclear at this point kind of what is actually being analyzed.
Okay.
Okay, so this might be really controversial for me, but I think that we need to reconsider looking at infant mortality rates in that we do, individual programs or individual interventions. Oh, sorry. The individual programs and interventions are not likely to change those rates in any dramatic fashion, in sustainable fashion. They may jump up and down based on something that was done but that wasn't sustained. So I think SACIM could make a contribution by identifying what the intermediate markers could look like, what they should look like, and what we could monitor on a year-by-year basis, and maybe look at infant mortality every 10 years when we do the Title V or when we do the Healthy People or something, because I think we set these markers, like I think the last set of recommendations said SACIM would contribute to a reduction in infant mortality by X%. When Arthur James presented at the first meeting, he talked about this 38-year lag. So it takes 38 years for Black infant mortality to catch up with the white rate. And needless to say, we all want that time lag to shorten, and that's the whole point of all this effort. But just bearing in mind that if it takes 38 years with what we're doing now, why are we looking at it annually and expecting that these little interventions here and there are going to change that equation? So that's my recommendation.
I'm hoping to facilitate specific recommendations by being non-specific. I apologize. Because my fear is we'll come up with a list, and lists don't work for advisory committees. There has to be a coherent strategy that links them together, and just the history of this committee and others have to confront some long-term antagonisms that I think we need to confront and overcome in our specific recommendations and the coherent message that they generate. First is the social determinants of health, which is usually antagonistic to intense clinical interventions, as if they are not strategically linked. We need to come up with recommendations that bridge that traditional antagonism. And I think we have, in some ways already, the substrate for those bridging recommendations that integrate both the social determinants of health and the clinical world. The second is I'm all for mom-baby dyads, but that's not new. The problem is that if you look at infant mortality, the majority of infant deaths occurring to kids, particularly in the African-American community, who were born in less than 26 weeks gestation, increasingly 25 weeks gestation. That doesn't give you a lot of time between when a woman knows she's pregnant and when these babies are being born to do some kind of intervention that's about pregnancy. The challenge, of course, is that in many ways our infant mortality problem, certainly the disparities, are a legacy of poor general health of women of reproductive age in the communities I've raised concern. So that bridging between what we're calling pregnancy-related issues and women's health prior to pregnancy is another antagonism we're going to have to address. My hope is that our number, the specific recommendations, but not a list, are framed to address these traditional antagonisms that have always undermined the functional utility of recommendations coming out of committees like this. If I could just add on to that, I think there's another antagonism between a view that sees healthy moms and babies
as a matter of 9 months prenatal care versus the longer life stage view, recognizing that it's the whole life history of the mom and perhaps intergenerationally that determines the outcome of that baby. And this conflict there is, what lane are you allowed to operate in? Everyone's comfortable if we just talk about prenatal care, but we know that's not going to get us anywhere where we need to be. What I wanted to offer was that we consider any recommendations we make, that we have both an overall, quote, from the World Health Organization, goodness goal, what are we looking to do for the overall population, and at the same time a fairness goal, what do we intend to do with the disparity. So we want to achieve X amount of the overall population, and we want to obviously eliminate disparities completely, but in a more proximal time frame, we want to decrease disparities by this amount also at the same time. And I think because the last SACIM recommendation just had an overall infant mortality, they didn't do an equity goal. And I think that's hard to do, both ethically and practically, but I think we need to get there.
This is Belinda again. So, one of the things we've been focused on in my own state is our infant mortality disparities. And when we really started looking at our governor's, he issued an executive order to say that we must address early childhood in our state. And our very first meeting, everyone around the table was saying, well, let's make sure we're addressing infant mortality. And fortunately for us, before the end of the meeting, we made that decision to focus on infant mortality disparities. We looked at the disparity ratio because we knew we could not see improvements without it, that it didn't matter what we were doing without addressing the disparity ratio, we weren't going to get improvements. And I think back to the early Healthy Start site. And I think back to, the original federally funded Healthy Start sites were charged with reducing their infant mortality rate by 50% over like a 5-6 year period. And we had several sites that were able to do that. Some didn't make 50%, but they did see improvements. And I think we need to also maybe take a moment to go back and look at those lessons learned to see what they were able to do in those communities for that short period of time. Because I would think that we would see in there that they addressed social determinants of health, they pulled all of their partners together, they figured out what could work in their community, and I think that's a piece that we need to make sure is included.
So if we could go to Janelle, are you back? Okay. Magda, and if Janelle, you come on, we'll let you talk. Magda?
Thank you. Having served on the Institute of Medicine's Women's Preventive Clinical Services Committee and coming out of the Affordable Care Act with the addition of the considerations for women's health, that's the inspiration for my recommendation. This is a season and a moment with the change and the expansion of the charter for us to be highly focused on women's health at this time. And towards that end, I'm ask us to consider how to build on that 2013 recommendation, number 1, around improve the health of women before, during, and beyond pregnancy. I encourage us both to seize this moment and to say this is building upon our predecessors' work. The specific recommendations last iteration was around clinical preventive services. And serving on the IOM, we were limited in our ability to look at community preventive services. In other words, what are the non-clinical services that would, in fact, be without out-of-pocket cost that would accelerate and enhance the likelihood of positive outcomes for women and their infants. So I encourage that we, through one of our strategies is a primary and intense focus and a lens of women's health, of course, braided with an equity lens, to essentially expand the work of focus on women's health from the ACA around women's preventive clinical services to community services that allow for systems of care outside of the clinical setting to have integration and proper reimbursement. So I can go more into that, but I think the model is there from the WIPC stuff that we can then maybe push beyond and define what are community preventive services for women and their families, and then look for the essential ability to be able to pay for it.
Thank you. Jean?
Thanks. And Magda, I'm just going to follow from where you are and say I think it's the Women's Preventive Services Initiative, WPSI, with its clinical implementation. There's an implementation task force or strategic group that's looking at all preventive services and how to implement across the United States. So linking to what that group is doing is probably a critical step.
Thank you. Stephen?
That another recommendation would be that the access efforts for the Strong Start implementation focus on FQHCs, rural health systems, and non-hospital community providers, which I think maybe gets to what Magda is focusing on doula service. I mean, in Minnesota, doula service is paid for ostensibly, but it's not because it's too complicated to make it happen. So I think Oregon and Minnesota are the only states where Medicaid pays for doula services, and that'll come a little bit later. And my argument for a comprehensive bundled payment, which will really force everybody to work together, and doula services have to be included.
Hi, this is Tara Sanderly. I think that we should recommend that we have dedicated NIH funds, that will be used to research, either basic science research or clinical studies that will focus on minimizing fetal and maternal risk associated with perinatal interventions, such as those of babies that are inherently, they're going to have inherent birth defects.
Okay, we just had Vijaya and Paul Weiss pass. I think this is an opportune time to make recommendations about both the preservation and enhancement of rural maternal care, both community-based pre- and postnatal care, preserve the readiness of communities to handle obstetrical emergencies, whether or not they have a hospital unit, which means including transport, and also looking at federal funding mechanisms to support the maintenance of hospital-based maternity care in rural America. I think it's what we're seeing with the closure is not, and the lack of access in these maternity care deserts is not an accident. It's a result of unintended consequences of policy.
This is Belinda again. I think we need to be very clear on what we mean when we say through an equity lens or focused on equity. Because I think it's easy for us to use that terminology, but if we're not going to do something different, then we're doing the same thing, and then we say, but it's through an equity lens. So I think we've got to be clear around this table. Maybe we need to discuss it this afternoon, what we're actually going to do this. So we're talking about making sure that all women and children have access to health care, that we can focus on that, that I just want us not to leave thinking that that's sufficient to get to the issues of equity. So I think we just need to have that conversation.
Janelle? I guess the definition is keeps doing the same thing, expect a different result. Magda?
Thank you. I heard the cautions earlier about being thoughtful to diverse perspectives. But we would be remiss if we're shifting our focus to women's health or expanding it, if you will, earlier in the life course, particularly in preconception, interconception period for women of reproductive age, if we did not take on reproductive justice, reproductive access. I think we need to show the moral courage that says that investments in and increasing access to reproductive choice, family planning, is an evidence-based strategy for intendedness of pregnancy and pregnancy spacing. And without being able to have access to quality reproductive choices, women are going to be disproportionately at risk for poor outcomes for themselves and for the next generation. So I would encourage us to from an evidence-based and rational perspective, add to our conversations about recommendations for women's health, a place for reproductive health, reproductive justice, reproductive access, and specifically family planning choices.
Thank you. Jean?
I don't think I've got anything else to add.
Okay. So we'll go back around. Steve?
Sure. Number 3 on my list of specific recommendations under that more general thing is to require the state Medicaid and Medicaid managed care organizations to provide equitable and sustainable reimbursement for Strong Start compromise responders.
I think if we're going to properly examine infant mortality and why it's there, then I think then we have to really carefully examine why some women choose to have induced abortions, and if there's something within kind of along the lines of what Magna was talking about, but not because I think that we need to increase access to reproductive choice. I think that, if anything, we need to look very carefully at socially why these women are choosing to induce their babies and induce abortion for their babies, and why that led to their decision. So I think understanding those community issues and why they made that choice will help us to also minimize induced abortions and therefore decrease infant mortality or increase infant mortality.
Well, okay, this is Jean Conrad. I just want to speak up about this topic. Access to abortion, contraception, those are basic rights and basic human health access. They are basic women's health. So trying to sort out a woman's need for an abortion, or to me, we're not looking where we need to go. Those are issues, and they are basic rights and basic elements of all health care.
Okay, Jean, I think there are many strong feelings around this.
I'm sure there are.
We want to certainly encourage an environment where everyone is able to speak. They're clearly about their views and have those views respected as their opinions or their views. But in this process where we don't evaluate, if you would like to put forth something when we come back around to you, you're welcome to do that. But I'd like to avoid evaluating someone's statement as we speak. So thank you.
This is Danielle. So induced abortions are not incorporated in the infant mortality rate. Those are not included in the files or how we would calculate the rate. So I just wanted to put that out there that while even if we do examine abortions or access or however you want to discuss it, that wouldn't impact the overall infant mortality rate.
Okay, again, let's save the discussion because this could be an extremely rich discussion to take us the rest of our lives. And not that it's not important, but I'd like to get everyone's ideas on the table to begin with.
I do. This is Vijaya. So a lot of the graphs that we saw yesterday, the maps particularly showed the South being particularly problematic in terms of maternal mortality, infant mortality, resources, et cetera. And so I think that it's a great opportunity to focus on what are probably structural problems, many of which are historical and man-made, but they're issues nevertheless that we have to tackle to be able to improve the outcomes for women and babies in those states. And so just as we might think about a focus on rural areas, if we could focus on the South and some of those southern states with really high rates and really try to figure out how to tackle those structural issues, I think it would also provide a blueprint for some other places as well.
Thank you. Give me 1 second. I had a brain cramp, forgot my thought. I think it would be helpful to, as we create a vision for the future, and this, I think, Jaya brought this up earlier, yesterday, is sort of come up with some notion of the basic community and healthcare and other factors necessary to have a healthy mom and healthy baby. As many women don't have access to those things or not, and cannot. And if we could paint a bigger picture, then we wouldn't always fall back into the, it's all about having prenatal care, as important as that is. Okay, Janelle, Magda.
My last one. I'd like to build on the 2013 and Strategic Direction 5 around data. As we have been blessed to hear extraordinary amounts of information, particularly related to women's health, and I am not certain there is a national data strategy that would allow us to have a comprehensive look at what the data are telling us, right? Specifically for women's health and to address maternal mortality and maternal morbidity. And so I'm curious about specifically hearing how resource impoverished and how lack of resources is curtailing the ability to have fuller integration of sentinel health review methodology, specifically whether it's Maria or FEMA or child death review or the other death reviews. And so I would just encourage us to, if the headline is, comprehensive, rigorous data strategy to integrate and bring to scale and promote the effective use of data to address maternal health and infant mortality. So it's a big bucket. As Paul would say, this is sort of structural issue. I think we need a data strategy.
Great. Jean?
And I guess I would say once again that it is access to health care, so having a strong statement about how universal access to health care, but whether it's preventive care or surgical care, because certainly cesarean sections and that fall under the surgical realm, that is certainly an element that contributes to maternal health outcomes and infant outcomes.
Thank you. Steve?
I'm getting near the end of mine. Another would be to define and initiate Medicaid bundled payment pilots for the entire maternity and newborn episode of care, because it really would address the doula services and all kinds of things, including neonatal care. And then also, my last thing would be just that I, as a member of the committee, commit to engage with interested public, private, and government entities in advancing these recommendations. I think we all do. That's sort of our next steps.
Thank you. Kara? Jaya? Paul?
Again, one thing to keep in mind is how the infant mortality, maternal mortality fits into, broader trends. the fertility rate in the United States is at an all-time low and dropping, similar to other industrialized countries, and which is of concern to a lot of people who could care less about infant mortality or women's health, and that we maintain, as we come up with specific objectives, think strategically about how our issues fit into these broader concerns around childbearing and demographic shifts within the United States.
So I think in order to create some continuity within the committee, similar to the Healthy People Initiative, it would be worth issuing a status update on the recommendations from the 2013 report, because in looking at them, we've made considerable progress on some and moved backward on others. Magda, Jean?
I'm done.
Okay.
I guess the only other topic I'd bring in is what I said in my introductory remarks, and it ties into what was just said when you look at decreasing fertility, is that there is an element of environmental exposures and environmental contaminants, environmental concerns that impact health.
Yes, thank you.
Right, and I was just going to add one thing as well to what Paul Wise's comment about the decreased fertility rates. Just looking at the Minnesota information, it was, I think, about 20 years ago, it was maybe 1 in about 50 newborns in Minnesota were born to mothers who were foreign-born, and now it's actually, I think, 1 in 15, which we're focusing on trying to serve those communities that tend to have more children, and I think as they are in the U.S. longer, they may go back toward the lower fertility rates. But, I mean, it's just something to keep in mind as we make our recommendations to meet the needs of those populations that are having more children.
Sarah?
Just kind of along the lines of what Paul was saying about decreased fertility, I think with that we are seeing a significant increase in vitro fertilization and these other means. And so I think with that, we're also seeing a lot of embryos that have been frozen and are either going to be donated embryo, adoption, or they've been in the freezer for several years. And so I think we need to also keep in mind just how people, as we look at infant mortality and how that fits in with this significant increase in reproductive medicine and in vitro fertilization.
The last comment, looking forward, we clearly have changing demographics in this country, and we should project forward what that means, because often some of our most populations of highest priority are having more babies than others. So we may actually see increases in maternal mortality and infant mortality if we don't finally address the equity issues. Linda? Okay, so on the phone, any comments? Or I think we've run out of time and maybe run out of brain cells for the moment. There's a couple of possibilities here. One is, as Belinda runs the afternoon, you may want to start prioritizing these. The other thing is we could consider some kind of a Delphi process or a Dela Cruz process, whatever it happens to be, to narrow this down. And what I would suggest is some of these are going to be high potential, immediate action recommendation, and others going to be long-term, and that might be one of the first cuts we make and then consider prioritizing. But probably with a Delphi process, 2 to 3 goals have a good list. Go ahead. It was Jean, or was that Magda?
It was Magda. I want to go back to Paul Wise's wise advice up front, Paul, if I can paraphrase you, that I also share concern about a laundry list, and I think we need to peel the wheat from the chaff here. there may be some immediate opportunities, because not everything on here has an urgent opportunity in the next 6 to 9 months of something that could move forward. And I think that with without a framework, without a sense of what are the core buckets, without a sense of our general approaches that we're going to take, well defined, I worry that these are going to be flashes in a pan, and that a Delphi process without some sort of criteria that is common, without some common framework, some common sense of how we prioritize versus our individual opinion, it may not get us the result that we want to get. So I would encourage a two-pronged strategy, Paul. One is perhaps taking a look at this particular list and looking for the cross-cutting themes and the buckets and do some sorting. And then within that, to be able to identify what might be immediate priorities or immediate opportunities to seize, and others which will take a little bit more fleshing out. Again, structure here might be very helpful, and it may be a way to also organize our work in between meetings, between a data bucket and a radical women's health, or a women's health bucket, or a day. You know, there may be ways that there are things that hold together. So I'm having a hard time without having that larger structural frame that we can all agree on.
I mean, facilitation-wise, the next step, there's two potential next steps. One could be coming up with a list of criteria, which could be what must be present here, actionable in 6 months, 12 months, and then what would be nice to have present here, and coming up with criteria like that. Another possibility, facilitation-wise, is a nominal group process where you would sort these out, you know, like a little stickies, identify the themes and buckets from the ideas, and then propose that as the criteria to use. So I don't know how we can do a nominal group technique process on the phone. I don't think we can. So, and I'm also thinking, I'm glad Belinda's running the afternoon. So you might want to comment, but I perhaps. So anyway, or there may be some hybrid of those two, but using these ideas to help create the categories could be helpful, but I agree with you. We need some criteria with which to make these judgments. Well, with that, it's lunchtime, so that gives time to think about this, and maybe I would offer to Belinda perhaps that might be something to talk about when we come back, but I will hand the baton to you.
So our afternoon speaker, Jenny Joseph, is joining us by phone in between other commitments. So if we can start right at 1 o'clock, that would be great. Make sure we have enough time to hear her and also discuss with her.
So we can talk after her presentation.
Absolutely.
And then after,
yep,
we've got
absolutely.
Latia and...
So we have Latia and Diana after Jenny Joseph, okay. And then that's really sort of the last formal structured part of the meeting, and then we have another couple of hours or hour and a half
for discussion.
Yep.
And try to move to next steps. Okay.
Right.
So if we can all be back, if we can try to get back like 5 minutes to 1 so we can start on time, that would be helpful. Thanks. Joseph on the line?
Yes, I'm here. Good afternoon.
Hi, Jenny. Thank you so much for joining us this afternoon. You're our first presenter. Just a brief background on Jenny. So Jenny is she's a British-trained midwife, reading from her bio, who fights to ensure every woman has their healthiest possible pregnancy, birth, and postpartum experience with dignity and support. Jenny has created what she calls the JJ Way, which is an evidence-based maternity medical home model, which focuses on delivering readily accessible, patient-centered, culturally congruent care to women in areas that she determines as the maternal toxic zones. Ooh, love to hear a little bit more about that. So Jenny is the executive director of her own nonprofit corporation called Common Sense Childbirth, and she's also the founder of the National Perinatal Task Force, which is a grassroots organization whose mission is the elimination of racial disparities in maternal and child health in the United States. So Jenny, we're going to turn it over to you. We have your slides up and looking forward to your presentation.
Thank you so much. I'm hoping that everybody can hear me well. I'm on my speakerphone, so please let me know if I need to get off my speaker. And thank you for the opportunity to present to your committee today. As the title says, I'm all about saving lives. I think that's really what we're all trying to do, and I'm thrilled to have an opportunity to be in discussion about that. Yes, I talk a lot about maternal healthcare as far as in maternal toxic zones, and I'll explain more as I go on. So I was able to attend in 2018 the HRSA Maternal Mortality Summit, and I wanted to kind of tie my remarks today back into the results and the information that we received as a result of that summit. I think it's really important that we keep looking at how we can build out from these ideas, these solutions, these best practices that come forward after we do this work. And certainly what was really exciting for me, what resonated with me at that conference was that so many of the things that we do and have been doing are echoed here in the solutions that were put forward at the end of the summit. I think it's worth mentioning them individually, even though, of course, everybody's fully aware, but I would like to just kind of point them out as I go forward into this presentation today. The access at the top just warmed my heart. You can't even imagine how excited I am to see that that came up first in one of the bullets here, that we talk about access a lot, but I think it's really important to really extrapolate on what that actually is and how it is going to be achieved. And so we can say improving access, of course, is going to be helpful, but how and who? And so that was really important, and I'm thrilled to see it at the top of the list. Safety, yes, of course. Again, we say improving, but how do we make sure we provide safety? And safety protocols obviously address clinical safety, but I think it's important to talk about overall safety, not just in the clinical sphere, but in the general sphere for women, families, communities to feel that safety and know where to access that safety. So I want to talk about that a little bit more as we go on. Workforce, absolutely. My charge today is to talk about other workforce providers that can help us in these efforts to eliminate maternal mortality once and for all. And so, yes, the workforce has to change. The workforce has to broaden, to diversify. We need to look at this as one of the main drivers of the change. We have to do it differently to how we're currently doing it in order to see those outcomes. Life course models, yes, absolutely. This is not a little 9-month period of time or, a couple of 6-week postpartum period of time. This is indeed a life course across the spectrum of a woman's life right through to the end. And then, yes, data, absolutely. And the committees that are in action now that are working very hard to figure out what can we do different. The action that is needed after the committees have made their reviews, the maternal mortality reviews and the infant mortality reviews, those are where we really have to be intentional about bringing change. And then, of course, the partnerships. So again, thank you for having me. And let's look at, I want to give a little quick background so you understand where I'm coming from. So I am a British trained midwife. I'm a Black woman. I'm a child of West Indian immigrants who went to England in the 1950s post-war. I'm the eldest. I was born there, raised there, educated there, finished my midwifery in 1981, and I've been in Florida since 1989. So in the United States a long time, and people keep asking me why I haven't lost my accent yet. I'm not sure if it's ever going to go anywhere at this stage of my life. But I really, when I arrived, was shocked to figure out that actually my midwifery training and my midwifery experience couldn't be put into play in Florida. I was a direct entry midwife, meaning I'm not a nurse. And so I was used to midwifery being normal, staple way of providing perinatal care for women and babies, and that there wasn't any other way to provide that care, that primary health care for pregnancy and women was delivered by midwives, and physicians supported the midwifery model by being available for complications and taking over from there. So I arrived, I couldn't get a job, couldn't get a look in. No one was interested in what I had to say. In fact, there was quite a lot of giggling and snickering and like, wow, what are you talking about? Midwifery, we don't do that anymore. And especially in the South, as a black woman, there was that connotation as well as, oh, that's so old school. We finished that. The grand midwives, the granny midwives are long gone, and we certainly can't make room for you. But I did find a way, and I kind of created along the way some of these different ways of being, and have been able to produce outcomes that are still at this point, very unusual. It is not common to hear that prematurity in a population of vulnerable women, marginalized women, high-risk women, women of color, can be so reduced to be under 5% every year. Like, that's just unheard of, and that's unfortunate, and yet at the same time it's exciting because it's there. It's proof that it's possible. I provide my care now in a birth center setting, but also in a clinical setting. And it doesn't really matter where midwifery care is provided, because midwifery care is patient-centered care. This picture here is here because I wanted to just kind of illustrate that for me, and I think for many of the midwives in the United States and the practices that are growing, we're looking for that collaboration in order to continue providing safe care. And in this instance, this mother was at the birth center for most of her labor and got to a point where she just could not move her baby down into the pelvis. After a couple of hours of pushing and trying, we went to the hospital to finish out the birth, and she was blessed to be able to get that baby born. But even though you can't tell underneath that blanket, that child was 10.5 pounds. Not going to get through without some extra support. She needed an epidural, she needed some more, she needed a vacuum extraction, but the baby was born safely, and so was she. The point was, though, that she chose midwifery. She chose to be out of the main system, and many women are doing that. And they're not only choosing midwifery, but they're choosing doulas, they're choosing to have lactation support, childbirth education, and so on, outside of the main systems. This is not to say that that's the only answer, but this is to say that you can integrate models with collaboration and interdisciplinary support for all of the different methods of providing care for women who choose to be centered in that care. So I think there's a safety issue here when we talk about how we provide safe care, and I think it's to do with making sure that if we provide patient-centered care, we are always going to land on the side of safety. So obviously, without belaboring the point, we know these facts. Babies are dying. We know that the statistics are always going to be at least twice, if not more, for African-American women as far as babies are concerned, but also as far as mothers are concerned. And now we're looking at the maternal mortality situation with much more detail, with much more application. We want to figure it out, obviously. We cannot have these statistics stand. We understand how unconscionable that it is, that where the numbers are rising, we are responsible and we must act. This photo is our Capitol Hill briefing back in the day, 2010, when Amnesty International first started speaking about maternal mortality and produced that report. It was alarming then. It's alarming now. It's important to keep in mind, though, when we talk about mortality, that we should not forget the morbidity. The number of 50,000, I think, is a very conservative number. When with my experience of talking with women and families, I would triple, quadruple that number in a minute. The women that are suffering post-delivery, they don't speak about it. They are not getting captured in our statistics. They stuff it, they try to go on. But we see, again, the disparity. Regardless of how many numbers are actually true, we see those disparities. So what is this maternal toxic that I'm talking about? So I made up a phrase because I didn't really know what else to do. And at that point, we were very clear about the social determinants of health. We knew that social determinants were really important to be addressed. and to be factored in when we talked about maternal mortality. So what happened for me, though, was as we began that focus on the poor neighborhoods and, you know, stress and violence in those neighborhoods and lack of resources and so on, I felt that we were missing a little piece, and my thoughts are still to this day that once we incorporate this thinking and acknowledge the impact of these structural inequities, we also need to look at these other areas where maternal toxicity shows up outside of these areas. So by that I mean, and I could use Serena Williams as an example because unfortunately she had such an experience that she has become an example. But as an affluent Black woman with means, with obviously enough you know, money or insurance to be well covered and well taken care of, she suffered. And she suffered because in this case, in her case, the maternal toxicity followed her. And that's why I think it's important to make the distinction between social determinants of health and the maternal toxicity of those areas, neighborhoods, zones, and the maternal toxicity that seems to follow Black women, Indigenous women, marginalized people in the United States of America, what I call pop-up toxicity. And the reason I'm really stressing this point is because that has to have an impact on the outcome. Serena made it through. She survived, but barely. We've all heard the story from Charles Johnson and his wife, Kira, who was lost during her postpartum period, and he was able to speak about the same issues in terms of having agency, having power, having affluence, having, you know, all these things, and still suffering because the toxicity then emanated around him and his wife. He was ignored. The situation wasn't handled. It was too late. Maternal toxicity is where the mother-baby pair is in jeopardy, sometimes because of social determinants, sometimes because of physiological risk, but sometimes because of the atmosphere, the response, the relationship, the bias, implicit or explicit, the racism, the classism, the sexism that comes at this individual through no fault of her own. We have some recent work where we're beginning to look at really documenting the qualitative experiences, but also now hopefully getting more into the quantitative as well, because we are getting enough data that helps us understand the mistreatment, the impact of the lack of respect, the impact of not listening. This work is through the Birthplace Lab in Canada, but it is American women. And it's important that this was also very community-led surveys and studies. And it really makes a difference when you hear from women what they're really experiencing. We go abroad and we talk a lot about respectful care and training and supporting other providers in other countries how to do it. But we've got a problem here in the United States. Being shouted at, even now, 2019, 2018, 2017, women having to experience this in the hospital, in their physician's practice, something's wrong. So I have created a model where we try to counter that. My fundamental question was this: could it be possible that creating a culture and environment that supports all pregnant women, pregnant people, could make the difference between health, gestational age, birth rate, and breastfeeding rate, particularly in women at risk for poor outcomes? I posed that question because we found that it's actually definitely the answer to what we've been doing. We start from the place of everybody wants a healthy baby, everybody deserves one. And this is what we get. So I've been providing midwifery-specific care, but I've been able to do that with the support of other providers, paraprofessionals, peer supporters, and volunteers. We've had to make do because of obviously not having enough funding and support to be able to maintain our model, but because there's such a volume of women who, when they are offered or have access to this kind of care, come running in droves. So we do have access as a real important part of our work. We do not turn anyone away. We essentially provide triage immediately when a woman presents, whether it's on the phone or in person. We work with her right there and then to triage her not only through her clinical needs, but what are her social needs? Does she have insurance? Does she have Medicaid? What type of Medicaid? Does she need help getting it? Does she need transportation? All of these things are part and parcel of our protocol, just as much as the medical protocols are. Now here you see one of our little ones. She's in charge of measuring the belly. Of course, that's not in the protocol, but a lot of times in this kind of atmosphere, when we provide this patient-centered, family-centered care, this is the comfort level that women and families have, and this is also part of safety. So we know that the application of a model such as this, where we're actually making an effort to bring in these specific pieces, access, connection, which is where we provide that, create that safety and the cultural congruence, cultural humility to bring a sense of peace and comfort to the family. Then we have knowledge where once you have trust with your patients, you can tell them anything and they will ask you anything. They want to know what they can do to have a healthy baby. And then lastly, empowerment. So the 4 tenets of this model are access, connections, knowledge, and empowerment. The main work, though, regardless, comes from a place of humanity, a place of recognizing that every woman and every mother-baby pair needs support, needs recognition, needs to be listened to know how we can best serve. These stats were obtained in 2006, 2007. In my area, I compared the stats from our clinic in the blue to Orange County, which is where we are located in Florida, in Central Florida, and then the state of Florida. Of course, these are old at this point, but unfortunately, you can see that in the African American women, the numbers were so high at that stage for prematurity and low birth weight. It's beyond belief, but during the course of the study, we only had 100 enrolled. They were enrolled prospectively, and we followed them through and waited to see what the outcomes were. These were clients who did not choose to deliver with the midwife at the birthing center, but were much more inclined to deliver with the hospital, and we encouraged and supported that. That goes back to what I was saying earlier about safety. The women who choose hospital because they feel safe there, makes sense that we would then support that they have a hospital birth. Even though they want midwifery model care, they want to be in the hospital, and we think that that makes absolute sense. So the African American women in our county and in our state at the time of this study were running around 20%. That, out of the 100 women we enrolled, we came back with a 0% prematurity, low birth weight that year. So we know that this intervention has some impact. We were able to eliminate the racial disparity, which at the time was the 2010 goal, the Healthy People 2010 goal was to eliminate racial disparities. We did that. We were able to find that we were getting an average birth weight of 7.5 pounds and 39-week gestation. 95% of the babies in our study reached those goals. These are women, I'm just showing some photos of women from my clinic. We had a day where we decided to do like a photo shoot, and we brought the moms in and we wrapped them and we posed them, and we just wanted to celebrate them. We wanted to have them see positive images of themselves. Where do you see beautiful Black women, full-term, healthy, thriving families? Where do you see mothers breastfeeding, mothers of color breastfeeding and being positively portrayed? This is such an unusual situation to be in when we have all of the money, the affluence, the resources, the power for everybody to be healthy. And yet, this young woman, I was present when she had a cesarean section for, she had preeclampsia. And I was there when I was in the OR with her. She had no other support. And she was feeling the operation. She could feel the knife. And she kept telling the surgeon, the obstetrician, I feel everything. And they kept shushing her. I've never, ever forgotten this experience. That mother went through the entire cesarean section feeling her pain. I felt so helpless. And it really gave me pause to realize that this is not how we treat people. The statistics that continue that say that Black women are more inclined to have low birth weight premature infants, they're more prone to preeclampsia, diabetes, obesity, all of these things that we have as reasons for these maternal outcomes are valid when you think about them in physiological terms, but they are there because of another factor, underlying factors, that maternal toxicity that I'm talking about. And we can only assume that's the case because the other races are not suffering to the same degree. The variable is not necessarily that something is inherently wrong with Black women, but rather Black women's experience is completely different. So we do need to address this, and I believe that using providers that are in the entry-level positions that are coming in from communities where they are able to return and serve those communities, it makes good sense. Their training can be quite cost-effective, it's much shorter, and it starts a pipeline to career paths, especially for women who are from diverse and marginalized neighborhoods. These are some of the women that work with me. The one on the left is a paraprofessional. She runs my classrooms and my waiting areas. The other one is now a registered nurse, bachelor's nurse, who's going into nurse midwifery. The third one with the pink stethoscope, she's a medical assistant and she's been working with me 15 years. And then the last one is also a medical assistant and phlebotomist, and she's been working with us for 10 years. These women are dedicated, they are connected to their communities, they're known, they're respected, and they provide the care as what I call midwife extenders, provider extenders, mid-level provider extenders very well. In fact, I would say better than we could possibly ever do because they have a relationship and can build a relationship of trust very quickly. We also do our clinics in Spanish and Portuguese. Here's one of the paraprofessionals. She's a doula, and she's providing some support to a Spanish language client and her husband while they're waiting. So just to reiterate very quickly, just to finish up here, the cornerstones of the model: access, connections, knowledge, and empowerment. And of course, the main work is towards the women themselves, the families themselves. But I want us to maybe, if we have a moment when we do questions, I'd love to have a conversation around, I see these same four cornerstones being needed to be applied to the providers, to the agencies, to the hospitals. We need for ourselves as providers access to understanding how we can improve quality for real, like really improve it, as opposed to do what we've been doing, which, you know, with all our best intentions, obviously is not working. I feel like we need as providers to connect with each other, to build our collaborative relationships and interdisciplinary relationships, to understand each other, to see where each other's barriers are so that we can work together to break those down and create the smooth, patient-centered care that we're all yearning to do. I believe we need that knowledge of understanding how we can take this information where we talk about maternal toxicity or implicit bias or racism even, and have ourselves get comfortable with these conversations that are not being had. And then we can empower ourselves and each other to really support what we would consider perhaps lower level providers. These are the workforce that we can depend on. This is where the volume will come. This is where the cost effectiveness will come. This meets the triple aim. And I think it's important that we encourage ourselves and empower ourselves to make these changes. So some of those solutions are community-based, community-owned, community-led perinatal providers. Across the board, community health workers, doulas, childbirth educators, lactation educators, that we are bringing in these other types of disciplines and working together. I believe that's what's protected in maternal toxic zones. It certainly has been the case in my clinics and my birth center. I believe we need to be able and willing to create and navigate this team approach to maternity care across the board. That way we're going to get the quality we're looking for, the cultural congruence that we're looking for. Okay, we're meeting women where they are, and we're centering women. And so I think it's time for us to look at the training and the support that other providers need, incorporation of other providers, Medicaid reimbursement for other providers, grants and funding sources for other providers so that we can move this needle. So again, access to safety, quality, appropriate level providers at all sites, in all areas, and that we have providers who can understand the need for that change and the students to get on board and let's go. So the task force is our grassroots organizing arm of the work we do, and we find that we are getting a lot more support for what we call maternal justice work. So along with reproductive justice, maternal justice is what informs this work, and we believe it's about changing the paradigm. And even though it sounds, so much more, I guess, airy-fairy, this is our goal, building a movement to birth a more just and loving world. And this is what we get. These are women from our practice. We had a group meeting, we had a dinner together, we had some fellowship, and I just think the picture speaks volumes. Access, connection, knowledge, and empowerment. And thank you.
Thank you, Jenny. We appreciate you taking the time to present for us today. The others in the room, we'll start in the room. Does anyone in the room have questions for Jenny?
Yep. Jenny, Steve Calvin here. Nice to talk to you again. I think I talked to you every month for the last 3.
Yes.
Thanks for giving the presentation. I always want to stand up and cheer once you've done it. And I have a question. So you are familiar with the Strong Start study results, correct?
Yes.
And how does your, I know that you have some different ways of doing things than the way the Strong Start was completely set up, but do you have any thoughts on how Strong Start might be implemented, or your kind of care model could be implemented in a global way?
Absolutely. And I think that Strong Start was able to, sort of make a nod towards this in terms of when they talked about the women who chose to deliver at the hospital anyway. One of the things that's really important for us to consider is that where women choose to be safe is where they choose to be safe. We can't dictate that, right? There's always going to be an element of the fact that the hospital, for most people, represents the safest place to be. So if we could then create a smooth transition from community-based prenatal care, hospital delivery, and community-based postpartum care using our physician, midwives, and paraprofessional extenders, we then now are part of the main system. What we have currently is that as a birth center, and I very much, of course, support birth center work, but I don't think we're going to ever have enough birth center providers or birth centers to impact the outcome of the poor maternal health and morbidity and mortality that we're seeing. So to get to actually eliminate or at least reduce these poor outcomes as sort of a hybrid model of birth center-based prenatal and postpartum care and support, or community clinic-based prenatal and postpartum care and support, with this increased team of obstetric providers, paraprofessionals in collaboration with the licensed professionals, and then the hospital as the central hub simply for the delivery. So to just extrapolate on that a bit, let's talk about the safety bundles that we're busy working on and we're busy implementing and we're encouraging hospitals to embrace. Those safety bundles address some of the physiological ills, and rightly so. But the safety bundle that's not being created is having the continuity with a provider such as a doula or a childbirth educator or a community health worker that follows you into the hospital and maintains that bubble of safety around you and works in an advocacy supportive role as a conduit, if you will, a navigator, if you will, throughout the labor and delivery experience as well. I suggest that's just as important as the hemorrhage part. So the Strong Start showed us that even in environments where women weren't delivering in the birth center, the birth center model, which is really essentially the midwifery model of care, was protected. Prematurity levels were dropped. So we have other models. Centering pregnancy is another model where prematurity levels are dropped. There are so many different ways of doing the exact same thing. The overarching piece is support where there is trust, where the patient and woman is centered, where cultural congruence and humility is standard, where the work is done to check the bias that might come up consciously or unconsciously. Those models, all of our models, whatever they are named, are the same at the end of the day. The rest then has to be, we have to discuss what is it that's a barrier for us to put them in place. Why do we have such difficulty with moving from, yeah, we've got the data, we've got the recommendations, we've done the review board, we've even done the studies, Strong Start being an excellent example, and yet, here we are.
Others in the room? What about on the phone? Do we have people on the phone that have questions?
Thank you so much for your presentation. This is Magda Peck. I really appreciated hearing the stories and the outcome. Can you tell us a little bit more about who pays and the financing mechanisms that, from a policy perspective, could support fully and embrace the best of your model?
Yes, it's an interesting thing. I feel like I might be the only one in the United States that gets away with this, but we are literally holding on fee-for-service with this model. I mean, there's times when, we throw our hands up and we're like, we're about to close because it's extremely difficult. But we are Florida Medicaid providers, and so we bill for our prenatal and postpartum care. Obviously, if I send the women in for a hospital birth, I don't get to bill for the hospital delivery, and that's a really big hit. But from a policy perspective, if we were able to build a global OB episode just like everybody else for this model, it would be perfectly, it would be financially viable. We do have some very small grants, but they are very tenuous, and we never know if we're going to get them, so we don't depend on them. What we do know is that there are other areas where we could really benefit, which is solid doula support, being able to build through the Medicaid for doula, being able to build for these wraparound services, being able to build for education. We can't build for any of these things right now and get reimbursed through Medicaid, but that should be an absolute imperative for anyone who wants to increase and improve maternal health. These are the services that keep these women healthy, that get us to the point that we can have 95% of the practice delivering a term and healthy weight baby. The postpartum is where we really shine. Our women are breastfeeding. They're not as depressed. They are getting back into workforce with much better health and conditions. So the postpartum support is completely bereft. There's nobody doing postpartum care. The recent policy that is in process that is going to hopefully finalize and allow us to build Medicaid out to the first 12 months postpartum, that's an amazing boon, except for who are the providers? Where are they? Do you see? So you can understand an obstetrician isn't going to want to see a woman at 6 months postpartum, even if you've got Medicaid. There's no real postpartum plan as far as clinicians or access to clinicians. So again, we could build a workforce of paraprofessionals and mid-level providers who could actually provide that postpartum care that we know the women so desperately need. The behavioral health care and support is not covered. We need that too. So I really appreciate your question. And I think we have, we've made it just by, really making it work. We take a lot of uncompensated care, but we make up the difference for it when we do actually deliver in the birth center, because we can then bill for the global delivery, which is a little bit more, lucrative than a fee-for-service Medicaid visit by visit. Currently, licensed midwives in Florida get $40 for a Medicaid visit and $34 for the postpartum Medicaid visit, and we're only allowed 2 of those visits currently. So policy would be so important in addressing and maybe creating ways, funding streams to support reimbursement of paraprofessionals, mid-level providers who are doing community-based work.
May I do a quick follow-up question, Belinda?
Sure, go for it.
Thank you. Jenna, can you tell me about, thank you for that response. You see women and their families at a certain interval, a certain extraordinary sacred time in their lives. And they also likely would be best having a primary care home, a place where they're full ability to thrive, to address the perhaps underlying cardiovascular disease, diabetes, weight issues, the behavioral health issues that are that she carries with her throughout her life course and that manifest sometimes later in her life. What is the interface between your model and the pocket and package of care that you give and the larger primary care for Well Women Care, particularly the Well Woman Visit as paid for by the Affordable Care Act? Can you tell me about that interface?
Thank you, Magda. Yeah, that's an excellent question, and it goes back to your first question. We really have no interface, and this is, again, where policy has to come into play. So while we focus on social determinants of health and put, effort and energy into looking into those areas, the fact is there is no provision for primary health care for women, indigent women, Medicaid-eligible women. That's not there. So I have a situation all day long where I have women who have needs for endocrinologists, who have needs for, cardiologists, and they can only get care in pregnancy because they have pregnancy Medicaid. And as soon as the pregnancy ends and the Medicaid ends at 6 or 8 weeks postpartum, they're back out in the cold. If they can apply for regular Medicaid, they may find it, but then they won't find a provider who will take it. So these areas are of not of the women's own doing or lack of willingness to try to find health care. There is no access point for them. And this is why I think it's so important when we're looking at these kinds of problems that we take it all the way back to what we said we were going to do as far as our solutions when we do our conferences and our studies. We come back all the time. I'm just putting my slides back because I think it's worth pointing out. You're talking about access, but this is the way I think we need to discuss access. It's all well and good to talk about improving access to the actual care as if the care itself is what we should be working on. But it's not. It's the policy that says your Medicaid runs out at this point, or your Medicaid isn't eligible for that point, or the fact that even the institutionalized way of being about Medicaid, oh, it's going to only reimburse this much, so now providers are hard put to be able to accept it. Or managed care taking over Medicaid, where managed care do whatever they want to do because that's what managed care can do. And so this is a difficult one to unpack, but it's relevant because the lack of ability for any woman who has a medical need to be able to find a provider who will take her and not use the emergency room, where once she's been triaged, she's told, go see your doctor tomorrow morning. Well, which doctor would that be and how? These are our problems, I believe. These are things we should take responsibility for, and we should troubleshoot and figure these out, as well as, oh, well, it's because she's not eating right. Do you see? I think this is where we have to really look at where are we being disingenuous around how we're managing this crisis and how we hope to see some change. So I really felt encouraged after reading and seeing HRSA's solutions written up and understanding from the report what they have learned, and at the same time also asking myself, well, are we going to do anything different, or are we going to be in the same boat having these conversations over and over? Because where the access points are not available, so people suffer, and so these statistics will continue. What changed for us was we removed the barrier to access. We take you whether you can pay, whether your Medicaid is good, whether you're undocumented, whether you're obese. We do all of the triage for you, uncompensated, to then find the right space or place for you and get you to where you need. But the minute you're not pregnant, we're hopeless, helpless, useless. And it doesn't matter how much talking I do and how many people I go to meet with and ask for support. If they don't take Medicaid, they don't take Medicaid. End of story.
Thank you for that. Thank you for the time, Belinda.
Thank you, Magda. Anyone else have questions? Gina, we really appreciate you coming. I think the message that you've left with us as we're sitting here thinking about recommendations today is, are we really going to do anything different? I think you made that very clear to those of us participating today, and I think that's a question we need to continue to ask ourselves. Are we really going to do anything different? And
Linda, real quick, I just want to mention something else before I go away. I wanted to say the other part of policy is, can we look at funding, training, and support and reimbursement for these paraprofessionals? They are really valuable and could make a tremendous difference very quickly and very cheaply. So I just want to put that back out there again, that would be another policy area to see that we could recognize these doulas and supporters. And thank you so much for having me today.
Thank you, Jenny. And we have had some conversations around doulas and community health workers, and I wrote notes for childbirth education and centering pregnancy. So thank you for your feedback and your comments.
Okay, thank you. Bye-bye.
Thank you. Have a good day. So thank you all. Thank you. If you're not excited about the work, I don't know what's been going on the last little bit.
Eventually ask Jenny to be on our committee.
We have David sitting in here. Okay, we are now, I think, supposed to have, is Latia on? Latia Davis, were you able to call in?
Yes, can you hear me?
Yes, Latia. Thank you so much for calling in. This is Belinda Pettiford. And we know you're with the Delta Health Alliance, but if you don't mind, could you introduce yourself? And then if you can just share a little bit with us around your work that you're doing around maternal and or infant health.
Yes, ma'am. My name is Latia Davis. I work for Delta Health Alliance. I am a parent educator here in Greenwood, Mississippi for the LaFleur County. My work, I work with prenatal women. We enroll them. We try to enroll them as early as, if they find out they're pregnant, maybe around 5 weeks, as early as that, so we can start tracking them throughout their pregnancy to make sure that they are healthy, that they are always attending their doctor visits. We try to provide resources. Here in the Delta, being that it's such a rural area, it's a lack of a lot of jobs, a lot of health care. So a lot of times, a lot of the women that I see, some of them aren't going to doctor's appointments because of, I guess, not being able to afford health care. I see that a lot of needs are in healthcare, and a lot of women that I just started this job maybe about 5 months ago, so I'm like fairly new, and I'm still getting to learn a lot. But a lot of things that I have seen that they are experiencing is, like I said, not being able to get to the doctor, health insurance, not being able to pretty much afford anything to pay for health insurance and get to the doctor's office. I was once in the program before I got hired. I had a parent educator, and I think some of the barriers for me, I dealt with gestational diabetes, and I also dealt with severe preeclampsia, which led to me giving birth to my second child at 28 weeks and 1 day. I feel like had I known, some of the things that I could access a little beforehand, we could have prevented so much of my health problems from going on a little further as it did, extreme as it did. I am so sorry.
That's fine. I'm sure someone's trying to reach you for some support.
I am so sorry. Yeah, like I said, the experiences here in the Delta, they are a lot different, a lot poor conditions, a lot of things that the women try to access that they're not all, and that's where I come in at to try to provide resources for the mothers, for the families, not just the mothers.
So, Latia, do you go out and do home visits, or you're reaching the moms wherever you can locate them or wherever they're most comfortable meeting you?
So yes, I do home visits, and I also will meet them wherever they feel, comfortable. But primarily home visits. I go and meet them in their homes, and we kind of do our visits there. Or like I said, if they want me to meet them somewhere that is comfortable for them, I will go there to them and provide those services for them.
Do you want to share with us some of the types of resources you're able to offer them, or either some of the needs that the moms are having, that whether you have resources for them or not, that could help inform some of our discussions?
Yes, I know a lot of families, they have trouble with housing, and we have someone who works here that can help them with housing. I know for our services, we provide, once they have the baby, we provide diapers and wipes and pack and plays for the baby. We also have a newly program called Delta Dads, and it's something to involve the dads into the program. We have, we have group connections for the moms every month, once a month, to just get the moms more involved and get them out talking and getting them involved into their pregnancy, I guess, to help them just share the information with us and open up a little bit more, which, like I said, I'm fairly new, so I'm still getting to learn some of the ropes, a lot of the ropes, along with the program. And I may not have called out all the resources because I know there are a lot more that we assist the mothers with and the families with.
Well, Latia, thank you so much for taking time to speak with us. I'm going to open it up to see if anyone else may have a question for you. Is that okay?
That is fine.
Okay. Does anyone have questions for Latia?
I do. Latia, this is Steve Calvin. I'm a medical doctor, and do you feel supported by the medical community? Do you interact with them at all? Do you feel like they're understanding the important role that you're playing in helping these moms?
Yes, I do. I'm also a part of the Delta Breastfeeding Coalition, and I work closely with a pediatrician at the Greenwood LaFleur Hospital. And I feel like now I have their support. I do.
Other questions? On the phone, anyone have questions there?
Latia, this is Magda. I just want to thank you so much for the power of your story. And I just want to ask, how are you feeling? And is your family and are your children well?
I am feeling great. It's been a year since I had my son, and he is amazing. My family is great. I'm grateful. I can say that I'm grateful to have my children and both of them be alive, especially around this time with the holidays coming up. I'm so grateful. So grateful. Thank you.
You're very welcome. Wanted to give blessings to you and your family, and thank you for being part of helping us do this work.
Thank you for the opportunity.
Hi, Latia. This is Vijaya Hogan. I wanted to ask if you could talk a little bit more about your transition from being a pregnant person in Mississippi to becoming a parent educator. How did you navigate that transition?
Well, my parent educator was very, very, very supportive of me. She's my mentor now. Being a mother at that time, I was totally not expecting, an opportunity like this to come around. I didn't know, the role played such an important, being a parent educator played an important role in a parent's life because, being in the program, I guess I took the advice and I took the education that they were giving me. But I never really thought that, that the roles could reverse and I could be doing the same thing. So the journey towards becoming a parent educator, for me, I felt like it was very smooth transitioning over because I already had I could say the experience from being a parent. So I felt like I kind of knew what the parents needed because of what I needed at that time. And so now that I feel like I have the ability to help a mother because I'm already a mother and I've already been in their shoes as being a participant in the program. So I feel like I can relate more to them and they are open up to me.
Very helpful. Thank you, Latia. We appreciate you taking time to be with us today and hope you have a good rest of the day, okay?
Thank you. Happy holidays.
Happy holidays to you, dear. Thanks.
Thank you.
Thank you.
You're welcome.
And do we have Diana on the line?
I am here.
Hi, Diana.
Hi.
Do you mind, this is Belinda Pettiful. Do you mind introducing yourself, Diana?
Sure. My name is Diana Jollis. I'm a nurse midwife in Tucson, Arizona. I work at El Rio Community Health Center. We're a large federally qualified health center. I'm also the chair of the American Association of Birth Centers Research Committee, and I've been very involved with the Strong Start for Mothers and Newborns program. I'm a faculty member at Frontier Nursing University. I teach rapid cycle improvement and implementation.
Oh, thank you. So can you take a few moments and share with us about the work that you do around maternal and or infant health that could help inform some of the decisions we're making here with recommendations?
Absolutely. I want to focus on the results of the Strong Start for Mothers and Newborns impact analysis. So this was a large, I think everybody is aware, a lot of investment, over $43 million went into this program. The impact analysis was released over 1 year ago with essentially no movement since then. Can you hear me okay? I was just hearing a lot of feedback. I didn't know if it was coming from my end.
No, we can hear you fine.
Okay, great. So, you know, through the CMMI system with regard to Medicaid, there isn't the same ability to move a model to scale that you see with the Medicare outcomes that come through CMMI. So this has been very frustrating. And I did fortunately get to hear Jenny Joseph the end of her presentation when I logged on a little early. I just want to echo everything she said that I heard and encourage you to avoid the temptation to come up with a new idea. I think that's where we do ourselves the most harm. The idea that, you know, maybe we could create a new type of medical home. We actually know exactly what to do. And if you read the outcome analysis, it's exactly what Jenny Joseph was talking about. She was one of the models within the Strong Start impact analysis. So it's improving access to the appropriate level of care at the appropriate time for all families. So an emphasis on the appropriate primary prevention. Preserving our physician workforce to do what they do so well and not expecting them to do things they weren't exactly even trained for or that they won't be as effective. So just in support of the previous speaker, we know for childbearing women that community health workers achieve 5 times the results with regard to infant feeding practices than a nurse midwife such as myself would. So we have to understand who can impact the social determinants, where, when, and how, and break the barriers down. As a nurse midwife and as a employee within the federal health center system and the National Birth Center movement, I can say with certainty that it's state-level barriers to practice. Every single state we're working in, we're having to go make legislative changes just so a nurse midwife can practice, just so a birth center can open, just so a birth center can receive reimbursement. So we're capable of doing better. Thank you, Morgan. I see Morgan put my slides up. I did just because I can say this, I can do this in 5 minutes. If we could advance to the next slide, I just want to make sure you're aware of some of what was released over a year ago. To the next slide. So this federal analysis looked at innovative models. It's funny, it's only showing like, it might not work. It's, Morgan, can we move out on it.
Sorry, since I just got them, the format's a little bit wonky. It's taking me a second to fix it. Sorry, but just give me a moment.
So the idea was to test innovative models. So we had the birth center model with community health workers. We had the medical home and then group prenatal care. So going down the next slide, the primary outcomes were trying to reduce preterm birth rates, low birth rate, and decrease the cost of care. And next slide. So I'm going to talk with you about the birth center model because that's what demonstrated the highest impact. These sites are in 45 states and 45 sites in 19 states, and over 60% were rural sites. So if you go to the next slide, one of the most important pieces to understand about the Strong Start impact analysis is that when we talk about birth centers, we're not talking about where a person is giving birth. We're talking about where they are receiving their perinatal care through the whole episode of care. So over 50% of these births were intended to occur always in hospitals because a woman wanted to give birth in the hospital or because a woman didn't qualify as medically low risk. So these are integrated care systems where women enter. They're cared for by a blended midwifery workforce, including nurse midwives, dietitian midwives, and a variety of different team members, many nurses, doulas, physicians. And then as their need for care increases, their level of care will increase. So if they need consultation with perinatologists, they receive it. If they need co-management, or if they need transfer of care. And all of these outcomes are tracked. So when I talk about these results, it's important to understand that I'm including our transfers of care. This is not something where I'm only telling you about our good outcomes. These are all of our outcomes, including when the women go to a higher level of care. And next slide. So this, again, the next slide is really just going to show you that the minority of these births were outside of the hospital setting. Next slide. The majority of the Medicaid population is capable of being cared for by primarily a midwifery workforce. So in this case, over 64% of the women never needed to see a physician anytime during the perinatal episode. Next slide. So our outcomes were good. We led to decreased preterm birth, low birth weight, very low birth weight, lower cesarean section rates. And of course, this slide, you say, well, gosh, why are you comparing to the United States? And this is always our issue. There are no randomized controlled trials on this topic. But the Strong Start is the most robust data analysis that's ever been done on this topic in the history of the midwifery in the United States. So next slide. We did case-controlled studies where Medicaid beneficiaries were matched to non-Strong Start, non-birth center beneficiaries, and they looked at outcomes. So when you talk about the impact analysis, these results are risk-adjusted, propensity-scored case controls that come from the same geographic region but didn't receive that model of care. So we're demonstrating a reduction in disparities. We do have statistically significant disparities in our outcomes. However, they are markedly narrower, and more research needs to be done to high impact elements of the care model, which includes community health workers. Okay, continuing forward. It's known, next slide, that our cesarean rate is lower. This is a supply-sensitive variation that you see when you have surgeons be the primary care provider of normal, healthy, pregnant women. You'll have higher cesarean section rates. So next slide. This is more about the impact analysis and how the claims data was used. Next slide. And this is the outcome. So it's going to show you the matched gestational age and what the preterm birth rates were with the Strong Start sample and with the impact analysis sample. So not only did we have lower preterm birth and all the primary outcomes, you see higher quality metrics, this lower cesarean section rate, which is a very important quality metric and has impact for life course health. We also have higher breastfeeding rates, and of importance across all race categories. So we actually don't have a statistically significant variation in exclusive breastfeeding on discharge by race, which we're really, really proud of. We do on admission to care. So on admission to care, for example, our Black mothers don't intend to exclusively breastfeed. On discharge from the facility after birth, we have no statistically significant variation in exclusive breastfeeding by race. You see metrics like weekend deliveries, and that becomes important because you're looking at overutilization of healthcare services. We have more spontaneous labor. Next slide. So I think importantly, this all led to, if all these quality issues didn't matter, or if that can't be the only thing that matters, they demonstrated that per Medicaid beneficiary, there was a $2,000 savings through the first year of life. This also related to decreased ER utilization for both mothers and babies through the first year of life. And next slide. I think to the point that you guys were just asking Jenny Joseph, the payment mechanisms don't support the model and the care that's provided. So the care is notably more time intensive, so our productivity is much less. Currently in my FQHC, a prenatal visit is reimbursed at $300 per visit, whether you spend 5 minutes with a woman or whether you spend an hour. And the midwives are spending markedly longer with the patients, but at great disadvantage for the health center. Next slide. So again, we do need to look at payment for quality and value metrics. We need to look at the workforce, the integration of the workforce, and the health of the workforce, the ability for people to get to a higher level of care when appropriate. And next slide. It's been an adventure trying to get this message out. Literally nothing has happened with these Strong Start results. Over $43 million has been spent. And next slide. We've done all kinds of things, and these are all, this is a photo of the CMMI evaluators and nurse midwives who are running practices in rural and urban areas. And next slide. This is currently, I don't know if you're aware, but the National Academy of Science is doing a revised birth site analysis to look at the state of the science on birth settings. And next slide. I think I'm towards the end there. Next slide. And next slide. And next slide. Oh, I do want to say this. So when you talk about what can we do, I think we need to look at our national quality strategy, and we need to really use our levers here. We can't just sit on this impact analysis. So we have to look at the science of quality metrics. We have our national quality indicators, but we have failed to actualize them so that, for example, infant feeding as an issue, as a valid quality measure, you can't go online right now and find out how your local hospital is performing on this metric. And currently, this will change soon, but currently you can't find out about the unwarranted variations in cesarean section. So we need to move on these quality measures, and we need to take action. We need to modify payment structure around them. But I would rely heavily on the levers that are already in existence. And last slide. So that is just it. I mean, the Strong Start impact analysis demonstrated the triple aim, and we're not doing anything with the data. Last slide. It's been hard to stay calm, I'll just say that. But carry on, I'm very relieved knowing that you are working on this issue, and if I can help in any way, I'm happy to share my expertise and insight. Any questions?
Thank you, Diana. Do we have questions for Diana? Anyone on the phone as well?
Thank you for a wonderful presentation. This is Paul Wise. What kind of pushback has there been for Strong Start? Who, with which professional groups or others are basically unhappy or contesting Strong Start?
I don't know of any pushback. It's just overt inaction. So the grant is there, the research is there, what we need to do is there. The system doesn't well support it currently, from a state legislative level to federal barriers. The Medicaid financing system isn't supporting it. So it's all of these broken silos, and basically what we've been told at the American Association of Birth Centers is to fight the fight independently at the state level. And this is being told to a group of professionals who are small business owners on call 24/7. The feasibility of functionally doing that, although we have accomplished a lot, and I'm very proud of our accomplishments, it's unrealistic. So I think there hasn't been overt pushback. We can't get the results published. I can tell you that the independent investigators at the Urban Institute have tried several high-profile medical journals that don't have any interest in publishing this. And that's interesting. It does promote a diverse workforce, which, by the way, never means a lack of physician. It's always our quality outcomes are because we collaborate and function with our colleagues. But what I'm getting when I'm in small circles or trying to work on this, everyone's pointing fingers at the other person. So when I was on a Medicaid advisory panel, it's not federal, the federal Medicaid systems can't control the state Medicaid systems. The state Medicaid systems claim to be powerless, that they can't control these issues because we're just a small voice serving a small group of people. So the power dynamics don't ever support the underdog becoming a primary model, right? There are a lot of dynamics with that. I will also say that in the federal impact analysis, one of the most important statements in the abstract was, while this model of care should be the normative model for all Medicaid beneficiaries, this will not happen anytime soon. And part of the reason is when you look at taking the model to scale, you would have to expand the model to include, for example, midwifery-led units, so CABC accredited midwifery-led units. Accreditation is a really big part of the national quality strategy, and it's very important when you look at spreading models like this. You would have to include level 2 hospitals and rural hospitals and embrace them and expand the model in these places. So it would have to go beyond a freestanding birth center model and actually expand to, for example, all of the federally qualified health centers in the United States. You have to take the infrastructure that's already there and right-size it to include the accredited pieces of this model. And that's the pushback. I don't know.
Thank you, Diana. Other questions?
Diana, Magda Peck on the phone. Can you talk about the preparation of the workforce and the relationship with academic institutions or other institutions that are both pipelining and preparing and then purposely placing folks that will sustain this from a workforce perspective?
Yes. So currently, just to give you a perspective, there are 60,000 plus OB-GYNs in the United States and 12,000 nurse midwives. So I'm just giving you a perspective of a chunk of the workforce. I'm not meaning to be exclusionary by not including other people. I work for Frontier Nursing University. We are graduating a third of the midwifery workforce. And we're graduating 300 midwives every year. And our model was designed around working with high-functioning, high-quality labor and delivery nurses who are out in rural communities or serving marginalized communities in places where maybe the nurse is unable to leave their family to go to a brick-and-mortar school in the big city that's 4 hours away, but we go out to them. So we were the first online distance education program before the internet existed. I said online. We existed before the internet. So we've been a long existent model of getting out there and training the next generation of nurse midwives in the United States. They, of course, have clinical preceptorship in their community. Many will travel outside of their community during their clinical time. All of them come to Kentucky more than once during their training to ensure excellence in their clinical skills. So there are up to 50 nurses with re-education programs in the United States. I'm less prepared to speak today about the CPM workforce, so we are united with the variation in types of midwives that are serving this country, and it's essential that we decrease the barriers to practice that midwives are facing, especially all midwives, including the non-nurse midwifery workforce in the United States. Did that answer your question?
Yes, it does. I'm going to push this a little bit more for information if I could. So helpful. When I think about the pipeline for the community health worker workforce in other parts of the country, not necessarily rural, the community college system has been stepping up. When I think about midwifery, I think about whether or not colleges of nursing in academic health science centers are stepping up, or other models. And I'm just trying to think about where we're in the context now of being at HRSA, Health Resources Service Administration, even thinking about the Maternal and Child Health Bureau, think about the investments of Title V in the MCH workforce. And I was just trying to navigate or understand how are current investments being made from a maternal and child health workforce and what you need in terms of midwives, doulas, community health workers, and an extended workforce.
Yes, and I am underprepared to answer that today, though I can refer you to someone. The answer to your question exists. There is a very clear ask, and there are a group of educators and leaders who are prepared to explain exactly how you would move the workforce pipeline to scale quickly. I agree with you. The infrastructure is there, and it requires funding. I don't have a handle on the exact answers, but we'll get that for you.
Thank you so much. Good to work with you.
Thank you.
And thank you, Diana. This is Belinda again. Thank you so much for participating today and being able to share looks like some really good information that you've had from the Strong Start work. So thank you and have a good rest of the day.
All right, good luck, everybody.
Thanks. So it looks like we have a little less than an hour, and we have several things on the agenda. As people can talk really, really fast, I'm thinking we need to prioritize some things. We talked earlier before Paul left, and we came up with some lists, and we were trying to figure out what criteria we may need for prioritizing that list. And I'm wondering if folks want to just spend a few moments now to talk about criteria, but before we jump straight into that, do we want to make sure everyone is clear on what we have made as our priority to focus on? You know, at our very first meeting here a year ago, one of the things that we talked about that we wanted to focus on was equity. You know, we made a decision as a committee and said we wanted to be leading with equity. I don't think we defined it, and I'm not sure if we're ready to define it now, and I'm not sure if everyone wants us to lead with that, to be honest. But do we want to spend a second or at least 1 or 2 minutes just to talk about what we want our focus to be, kind of what our vision will be for, you know, this iteration of SACIM? If folks want to talk about that a little bit. The answer could be no, you don't want to talk about it.
I think, this is Vijaya, I think we have to, because I think earlier Magda or somebody else suggested picking low-hanging fruit. And you could go down a lot of rabbit holes doing that if it's not within some larger structure that is coherent and cohesive and that is going to lead us to the outcomes that we're going for. So I think the visioning thing is really important. And about the equity issue, I think that's paramount. I think that's the fundamental crux of what's going to take us on a path away from the status quo and towards that transformation that we need to see some changes in the outcome.
Thank you, Vijaya. Others? Well, I've heard about 4 or 5 different kind of buckets, or if you will, a framework. And I absolutely agree with you, Vijaya. Doing the immediate opportunities in the absence of framework is what I said earlier. I think it's not as productive. At the same time, there is an urgency for us to set that structure so that we can move towards action. So it's a necessary tension. So thank you for naming that. How to organize it, there's lots of different ways, but I want to put out and ask for Paul Wise's help, who is also suggesting some sort of cross-cutting themes from what I think we've been talking about for the last year, in particular for the last day and a half. Certainly the notion of clarifying and cementing equity as not only our centering principle, but one that we can offer clarity and meat to so that it doesn't just become rhetoric. So equity is one. A second, with greater opportunity and urgency, is because of our expanded charter, to put the lens not starting at infant mortality and embracing life course, particularly in the short run, to ask about maternal health, maternal mortality, morbidity, and women's health more directly. So that's the second sort of bucket of cross-cutting. What are the unique opportunities to look through that lens? Define it, and then identify short and longer-term strategies. A third that I heard has to do with the tools we need to be able to do the work and to inform us from an evidence-based perspective. And that has to do with both data, strengthening the data systems, integrating them, getting them used that we have, example being the Sentinel Health events and the review methodology. It's just one of the last 2 days that need to come together more cohesively, and a broader research agenda so that important questions are being addressed and answered in strategic and bold ways. So equity, maternal health, and data. And then last is the bucket that has come up around access and quality of care for women before, during, immediately following, and beyond pregnancy. And so I just would like to, it helps me to begin to sort it out, knowing that our criteria will fit our basic strategy. And that we might have some ways of sorting things out that can make a little bit more sense. Paul, you're one of my best framing people that I know in the world. You have a different way, I'm sure, of approaching it, but can you help us out here?
Don't put me on the spot, Magda, but thanks for putting me on the spot.
Always.
Yes, I can count on you. I am sensitive to being specific enough to come out of today with some focused purpose and some strategic objectives, particularly if we are going to burden HRSA with concerns around more meetings or more support. But I do like your framing discipline, Magda, and would sort of try to extend it to something that addresses, that bridges the different concerns we've talked about, but also what we've heard over the last hour. And that is a focused strategy that bridges the social determinants of health and gaps in clinical provision. Straight clinical provision, but also the integration of essential support services that we've heard both work, have been identified, but are not being utilized adequately. So I keep coming back to CMS. It's part of this department. It's not even an 800-pound gorilla. It's the 10,000-pound gorilla for the communities we worry about. And as you heard, the Strong Start is sort of sitting there. I, over lunch, was looking at all the websites for CMS on childbearing and on perinatal outcomes. And 2014 was about it. And Strong Start. And then nothing since. So would it be appropriate to ask CMS to quickly inform this committee of what the heck they are doing to improve birth outcomes and reduce maternal mortality? It's a simple ask. I've been on a bunch of other advisory committees, what the heck? And that's a nice way, obviously, of saying that. But we've heard in the last hour, over the last day or so, the concern that the financing mechanisms are not only obstacles to many of the improvements that this committee and other committees have proposed and recommended, but that there are enormous opportunities and brain power and creative people at CMS that have supported innovations in other domains, but not in this domain. So let me stop there.
Yeah, so this is David. So to Dr. Ellinger's credit, and perhaps after talking with many of you, we did extend an invite to CMS, to multiple parts of CMS. We heard back that the Office of the Administrator would be better positioned at our next meeting, and they weren't prepared to present at this meeting.
That tells you something, other than they're very busy and maybe totally appropriate. But I think we need to put on their agenda that we're heading in their direction. They may not care, obviously. They've got a million committees giving them brief all the time. But the question for us is, do we feel strongly enough that financing mechanisms, particularly Medicaid, CMS, are important enough to move the committee in this direction and request, strongly request, with courtesy and recognition what they have on their plate, that they inform us how they view this arena of activity. And if they don't come again, well, that tells us a lot about how they view it. If they come with good data and ideas and actually activities, that would be very helpful for us to give us confidence in what they're doing. And if not, perhaps a basis for collaborative dialogue.
So if I may, in the interest of sort of discipline in the process, I think we're talking about a couple different things here and different types of recommendations. Dr. Wise, what it sounds like you're referring to is more of a sort of a short-term action step as to the committee sort of calling out that given your role, you feel it's necessary to have, and I'm not wanting to put words in your mouth, but that you would like to have CMS make a presentation and discuss where they're going, with the idea that as a sort of a secondary bucket would be to assist the committee in addressing financing, blah, blah, blah. And
the action steps that I'm suggesting, and Melinda and everybody else chime in, is informational. Help us to understand how they view this, what they're doing, and what their plans are, because we think it's essential that they be part of this conversation. Subsequent action steps will be based on this.
Right.
This is Belinda. I think we would also want them to be able to help us kind of strategize around things that they could be doing that maybe they're not doing. You know, so it may be the whole conversation around doula support services. You know, we know there's a handful of states that are trying it, but they're struggling with it. But is there something that CMS can help say, well, you know, have you thought about it this way? So I think we would also want them not to just present, but to also stay engaged and help us to strategize.
Well, my question on that point goes to, yes, I think that things that you're asking for are logical, and there's a progression in that logic. Back to the point that Paul had raised a couple hours ago about, or maybe it was you, the other Paul, talking about timelines and, you know, delaying for the next meeting is exactly what are you asking for from the perspective of the ability for the committee to move? Because if you're asking CMS to be responsive, are you wanting that responsiveness to be 6 months from now when you have your next meeting, or are you wanting that responsiveness to be in some other way at some other timeline?
Sure. This is Paul again, Paul Wise again. The ghost of Paul Jarris is still swirling around here. My view is, again, a presentation, but within a month or two to give us some fact sheets, just a very short memo to outline what they're doing. They have a newly announced rural initiative that looks very important and likely to have resources behind it. Well, what part of their rural initiative includes childbearing, women's health, perinatal health, maternal mortality reduction? Just a memo to give us headed as quickly as reasonable, I think would be useful. I mean, these are my suggestions. And if it appears, as I expect, that there's substrate there, then to participate, not just the presentation, but to participate to understand what we're supposed to be doing, but also to perhaps integrate issues more fundamentally into what they're doing. Is that reasonable?
We do have 2 ex officios from CMMS who just, one has been online the whole time.
Can I ask a structural question, Belinda? This is Magda again online. It would seem to me, because it's, again, how we organize our work versus what are our priorities. One of the things I think that was useful coming away last December was, although we're not going to meet for potentially, you know, into the spring, that there was the activation of working groups to be able to work in between addressing some very specific challenges, with the understanding that it would be engaging not only other members of SACIM, but others that are partners in the field. And so I'm wondering if this particular focus around financial access and better understanding and maximizing the resources through CMS, particularly to fund an extended workforce and to work on reimbursement and other issues to advance maternal health and reduce maternal mortality and infant mortality, could be a working group that takes the lead to frame the questions, to approach CMS, working with Ed, of course, and then activating this and as an assignment. And I can think of no one better, of course. I'm going to talk to you, Paul, about that. But I think, you know, putting our activities and our actions where our passions are, what we think is most important. And so I could imagine that those around this table who feel strongest about financial access and leveraging CMS and bringing in that, whether that's Stephen or whether that's Paul, those that feel strongest around data and research and really being able to dive deeper could organize around a data and potentially research agenda. And those that truly are going to ground us and help us further to go from word to deed around equity could be a third working group. I'm just trying to think of some way to not just prioritize what we're going to do, but how are we going to organize the work, and folks that will rally around the sort of the driving anchors of the next 6 months to keep the momentum going. Just an idea, and I have no idea what the faces are in the room because I've been disembodied all day, but any thoughts?
Thank you, Magda. I actually had just written a note that said work groups here on the notepad, so we were thinking in line. I think what we need, though, further clarification on from the group is to see if folks are interested in the framework that you propose, because you proposed a framework with like 3 or 4 buckets, and then Paul came in and did more of an overlay of it around the focus with CMS. One, which is, like, as you say, one specific bucket that actually focuses more on the access and quality of care area. So are people comfortable and okay with the buckets from the framework that Magda is suggesting?
All right, this is Paul.
Go ahead, Paul.
I would want to separate clinical or quality of care from the social determinants, because the burden I'm throwing at CMS include both, because some of the pioneering work that you will be doing when you get a budget in North Carolina is using CMS support to do a bunch of creative things for community development and social support. So I wouldn't separate the clinical and social determinants, but I do see the buckets that the categories that Magda presented as very useful, particularly as we develop working groups, perhaps.
And I would push to maybe, I believe in the powers of 3. You know, people don't remember the 4th thing. That if we were to agree that through, given the opportunities and momentum around maternal health, and because it is the newest part of our charter, we would look at maternal and child health and the first bucket, equity. Maternal health and equity. Maternal health through the lens of access and quality, both clinical and extra-clinical, into larger upstream social determinants. We would look at data and research, knowing that there'll be overlap, of course, between, and as we braid later, then we can braid what comes out of the equity with access and quality, with better research and data, and see if we've got a more cohesive strategy 6 months down.
So this is Belinda Magda. So are you suggesting that we separate out the maternal from the infant health? I just want to make sure my notes are capturing what you're saying.
Not at all. No, I'm not saying that at all. Please, it's always integrated. I'm just saying that as not we're separating infant health, but I'm saying that
the initial focus.
It's so big what we're doing. And I know that infant mortality has been the driving force of SACIM since 1991. But we have this new part of our charter, and it's not to exclude, but to rather include in the dyad, if you will. So I'm just suggesting that in the spirit of an expanded charter, we look at maternal health as in the context of outcomes through 3 different, and come up with, and look at that list that we've generated of what opportunities, and sort it out and have working groups around championing and advancing equity, championing and advancing access and quality, both clinical and bridging to social determinants, and championing better, more accessible data and research to inform our work. That's what I'm suggesting. Any clearer?
It is clear. Thank you. So what do people think of those 3 specific buckets? Are you good with those? We narrowed it down to 3. So the first bucket will be around clarifying champion equity. The second one is more around access and quality of care, which includes social determinants of health. And then the third one was around data and research. There wouldn't be a separate maternal health or an infant mortality one because they would be interwoven in all of the other ones.
Correct. That's what I'm proposing. And just, again, I'm trying to, in our limited amount of time, see how to organize how we continue this conversation so when we get to 1:15, there's a sense of where each of us will align our commitment and time and passion to continue the work once we're beyond the capacity of today's time.
Yeah, Magna, this is Tara Sanderly. I think this makes a lot of sense, the three buckets. I think my only added suggestion is that access and quality of care is a really big topic, especially when you look at clinical and social. So I guess we might be a little larger subgroup. Yes, that's the only thing I'm thinking.
We have 11 members.
I just feel like that can be easily, that social and clinical, if you're going to be looking at both of those, that's pretty big. Just from my own experience, just as I mentioned yesterday, that just access to advanced technologies alone is a huge topic, let alone just some of the simple clinical things like ultrasound. So.
And this is Belinda. I don't guess there's any reason that we could not pull other people into work groups. So the work groups
that is the point.
Yes.
Yeah, that's absolutely allowable. Yeah.
And in fact, this is an opportunity to invite Jenny to come in or others so that people who we know are leading edge in this can have a more focused way to contribute to SACIM, which might lead to later, roles or responsibilities. But we want to tap the best people now that we can coalesce around the driving opportunities that are shorter term and have a sense of urgency. Because as, Janelle would say, babies are dying and moms are dying. So I want to keep that sense of urgency front and center.
Yep, Steve here. So I agree with all these things, and I might be somewhat naive because I've been on a few committees, but not as many as the rest of you maybe. And the way I look at it is, we could still look at things, and I think though we might want to be doing things, and we can continue analysis throughout the whole process. But unless we do something with regard to real action, as far as a specific request or recommendation, maternal child health right now is at top of mind of all over the country. And the three parts, I agree with that. But my question is, I would suggest that we at least maybe after this meeting we come together, we come up with what is the exact recommendation. But maybe we should put together a specific recommendation on the Secretary's desk regarding implementation of what Jenny Joseph was describing, what Diana's describing, and also, to Paul's point, maybe in that process, asking CMS for what they're really doing now, saying, what are you doing now? Here's what we're recommending, because we want to be respectful, because they may say, hey, we've been working on this, and we were ready to announce it. I just don't want, Jenny, Joseph, and Diana, and the people in the trenches to feel like, okay, they're still idling the car. We're not driving down the road anymore. We're out, cleaning the windshield. I really feel like something that comes out of here should be quite specific, especially to CMS.
Thank you, Stephen. Question to you, David, a process question. So I want to be clear. The process is we come back with do we come back with like one recommendation at a time, or do we just do a full report?
You can do whatever you want.
We can do it either way we want.
Yeah.
Okay.
So we've done it both ways.
Okay.
So we have definitely had just a letter to the Secretary, just alerting her at the time of what you all were doing as a committee, and then everything to what the last committee did under Kay Johnson's leadership, where it was an 85-page report, and then each subsequent meeting after that operationalized each one of those 6 categories. So it's up to you all, absolutely up to you all.
Thank you for clarifying
and we're
that.
here to help whatever you want. So just another process point is Not only are you encouraged to invite other people to be part of these work groups, it's actually because of the Sunshine Act, they can't be closed. So you can talk about how they are involved and participate, but we won't be meeting behind closed doors as a committee. Not that anyone implied that you wanted to do that.
Thank you.
Were you saying something, Magda?
Yeah, I was just going to support Stephen's pragmatism and respect for our colleagues in the field. My thought is that if we self-organize into three groups among the 11 of us, our number one charge is within a month, or here we are in December, by the 15th of January, no later, we will, in our smaller group, distill out a specific, concrete potential recommendation to the Secretary, potential request for more information and data, potential request for presentations into the future, request for insight from the other two groups. And so the idea is that that we get to do the distillation of everything that's been produced in the last day and a half, particularly this last laundry list, which hopefully can be available sooner than later, could be distilled out through the three different bucket groups, or three different working groups. But each group has the same task. What are the immediate actionable recommendations? Although, because I don't think it's realistic that we're going to come up necessarily with, we may come up with this one right now, but it might be a little bit better in 4 weeks, and I'm not sure the 4 weeks is going to make a difference. Someone can tell me otherwise. But we refine it a bit, and so that the products coming out of each of the working groups are potential draft letters, or at least components of a draft letter to the Secretary, or the HRSA administrator, requests for additional information and that we need to have to follow up on today and future work, and recommendations for priorities moving forward and what we want to see at the next meeting. Again, I'm brainstorming here, but it would seem to me having a similar charge or task for each of these three groups to do, then we crosswalk, crosstalk. Then by 1st of February, which is not that far away, we would have a far more cohesive approach, because when we approach the Secretary, I want to make sure it's not hit and miss. And all of that said, if there's one driving thing right now that has such urgency that we should form it right now, then we got 30 minutes to knock one thing out now if we think it needs to get out the door before the first of the year. That's how I think about it, but putting it out there for others to consider.
Yep, and thank you, Magda. I agree entirely with you. It's good to be sort of tempered a little bit of saying, I'm sort of an obstetrician. I just want to get the baby out, and be hopefully let the mother do that work too. But I not prematurely, no. But I agree. I think what you've outlined sounds good to me. I don't know about the others.
This is Belinda. I'm not sure if we have to do a letter to the Secretary. We just want additional information, because we can just send that to you, correctly? Or does it need to go a formal letter? So like if we don't need to do a letter for CMS that we want this additional information because it's already in motion. Or did Ed do a letter on our behalf?
He did not, no.
Okay.
So he just asked me to reach out to CMS and have them come present.
Got it.
So it was as simple as that.
Okay. So again, going back to the three buckets, is everyone good with the three buckets? Can you just say yay or nay?
Yes, Steve.
Yes.
Yes, to start.
Yes, in theory, but I think we can word it somewhat better over the next couple of weeks.
Thank you. Jeannie, are you still on?
So Jean had to go to another meeting, remembering that she's 6 hours ahead. But Janelle is back now.
Janelle, are you back?
Yeah, I am. And I heard a little bit about the three buckets. I believe it's still a work in progress, so I agree.
Okay. Thank you. So people agree to at least use these as our draft buckets for the moment as we continue to work to formalize them. So do we have folks that are interested in Magda? Are you in agreement with them?
I better be, huh?
No, you're right. She needed to be on record. Thank you, David, for keeping us in check. Thank you, Magda, for agreeing. So we have these 3 draft buckets, and now if we're moving this into more of a work group format, we need some people to volunteer to be on all of these work groups, and we need probably at least 1 to 2 leads on the work group so someone can at least call a meeting and get it started. So who is interested in access and quality of care, and as well as bridging social determinants of health? Yes, Paul, we didn't look at you, but you can always say no.
Not to you.
Thank you, Paul. Others interested in working with Paul?
You'll take me. I'll work with Paul.
Sarah and Stephen. Everybody can't be on the same one, but okay. Thank you. And we're missing some folks still. What about data and research?
I'm happy to step forward with that one if I have a partner. This is Magda.
Thank you, Magda. You probably can get a partner. They may not be in the room now, but there's some people missing. We could either make them assignments and they'll regret having left early or not being here, or we can give them an opportunity, because we still need to have this conversation with Ed and follow up with him, because he is our chair.
Yeah. And I would recruit Paul to work with me, Tara. Vijay, you're the one who pushed for the research side, but we'll consult with you because I figure you want to throw your ring into the other hat.
Yeah, I can't say no to you either, so I'll help in any way I can.
So Paul is going to multitask. Vijaya, you want equity?
I was thinking Paul Jarris as well.
So was I. I was volunteering him.
Oh.
I thought we should volunteer the other Paul because he's not here. But, you know, the bottom line is everybody, what I consider here, Belinda, helpful for me when I think about signing up to stuff is I think about, am I playing a level 1, 2, or 3 role on this? So level 1 is I'm going to step up and co-lead. Level 2 is I'll contribute as I can. And level 3 is I promise to stay informed. So I think you're asking for folks to look for, you know, where are you willing to be a level 1? And then, you know, knowing that the level 2 will be there with each other and everybody will stay informed across all 3. So I'm willing to step up to a level 1 on data, and I thought maybe Paul Jarris and I could do that together.
We'll put Paul Jarris down with you. He was volunteered today, one or the other. And we're going to volunteer Ed for equity. He may change his mind, but we'll volunteer him for the moment. And Vijay, and I'm interested in that one as well. So did we miss, Janelle, do you have an interest in any of these areas?
Yeah, I'm interested in equity and access. So I can help out in both areas.
Okay.
Yeah, that's a level 2 in both areas. Amen.
Thank you. And then we're missing... Oh, got it. And Jean, thank you. Jean and Colleen. Do we assign them things and then...
You might want to assign.
We can ask them.
You know, it might want to assign Jean to the access and quality because as a neonatologist, that's still practice.
Yep.
And then we'll assign Colleen to the data.
Did I say Jean or did I say Colleen? I meant Colleen as...
You meant Colleen. Oh,
I'm sorry. Yeah.
I meant...
Right.
We'll put Janine under data and research until she tells us otherwise. Okay. So we have our 3 buckets, our 3 work groups. We have leads. So Paul, you're going to lead the access and quality of care one. Magda, you're going to lead the data and research. Vijaya, will you lead the equity one? So we've got leads, and then from there. So what is our timeline? When do we want the work groups to have met and at least come back with some next steps?
So can we repeat what those next steps are? Because I think I heard an actionable recommendation draft 2 questions or a list of what we don't know or requests for additional information, 3 potential presenters for the next meeting, and was there something else?
You actually have more notes than I do. Let's say that again. I do have.
Vijay, you were listening very well. I'm very impressed.
Could you repeat yours, Vijay?
I have actionable recommendations, a draft of that, not anything near final. 2, list of what we don't know, request additional information, and 3, recommendations for future presenters that can inform these recommendations or give input on them.
I would add 2 other action items, if I could, not to stretch this too far. But consider the first one, recommendations, as being also priorities. In other words, we will have the whole list of what we generated collectively today. And it would seem to me that each of the working groups would glean that for what are, pull out the ones that are most related, and then identify which ones you think might be recommended priority. And if there are any specific, instead of calling them recommendations, I might, borrowing from Stephen, call them actions. What are some actions? They may take the form, and hopefully they will take the form in specific recommendations. So it's actions/recommendations. That's how I would augment the first part. And the last is that if you're going to co-lead this, then you've got to be able to think, who else, listening to David, who else needs to be part of this? For example, I would love to think about tapping the people who spoke to us today and yesterday about the whole Sentinel Health Review methodology, to have a conversation, and perhaps, a subset of the people who were here today, whether that's Wanda, folks who presented from Maria, folks who presented from FEMA, folks who presented from Child Death Review. We should tap the people who we've worked with and ask who else needs to be at that table. So I would just add the who as a final piece to our work. And I trust that people will, if you have recommendations of who, tell folks, and if not, go for it and keep moving.
Can I just get some clarification? So Magda, was the first additional 2 recommendations that you listed to understand the intersection between whatever that actionable area is and maternal health, infant health, and that list that we generated today? Is that what you said?
That's what I'm hoping, is that we will use what we generated to be able to then distill it to find out what do we need to know more about, who else needs to come see us, and what are our priorities from what's been generated, and are there any action steps that we'd like to push right now?
So this is Belinda, so you're basically saying all of the work groups need to take the list that we came up with earlier today and see a couple of things. One, does it apply to your work group? So it may be the bucket that it falls over into, I think, would be one of the first steps. Is that what you're thinking, Magda?
That's exactly right. In other words, we need to be able to process and distill what we generated over the last 2 days. And the way to do that, I'm thinking, is to do it at the level of the smaller working group, each one using the same common information. And then my thought of Ed's role is to look across the 3 and make sure there's nothing that's being dropped.
And then within the work groups, I guess the work groups themselves can prioritize the different lists as well.
That's right.
That apply in your own work group. Got it. Other comments for folks?
This is Janelle. I just want to make clear, I thought I heard maybe from David Dela Cruz that, is it in the work groups or is it in subsequent meetings that we have that we can invite people to listen in and participate?
That actually can happen in either one, so it can happen in both.
Okay. Mm-hmm. So should we as a group, should we meet offline to kind of talk about that, if I'm thinking of someone I think would be great in access, to invite? Should I wait to talk to the group before doing that?
So this is David. So part of what we can do at HRSA, not through LRG because they have a contract, is we can help support webinars, Adobe Connect meetings, teleconferences. You feel free to email yourself as much as you want, but once you're ready for a teleconference or a webinar, let us know and we can help facilitate that.
And I think, Janelle, the other thing is when the work groups that we just named should meet first, and the discussion happens in that work group about who else you invite.
Perfect.
All of us going out inviting people on our own now, because I think we need to have the conversation within the work group first.
Perfect.
Okay.
That makes really good sense. And the question I would ask is, could we challenge folks to set up their first work group meeting before the 15th of January?
Looking around the room, thinking December is gone. But if you're saying schedule it, or are you saying hold it? Those are two different words.
Have it happen in January.
So if everybody
your
meets
first
by,
call.
if everyone meets by February 1st is basically what we're saying.
Can I make another comment? So we have all of these ex officio members like you, and I wonder, can we integrate you into these subcommittees as well?
Yes.
It's allowable, absolutely. Yeah, there's a reason why they were chosen, for sure. To add the federal subject matter expertise.
And they have extra time on their hand. Is that
So much to spare. This is Wendy from ACF. I just wanted to add that it might be of interest to the group if you invite people to your subgroup to talk, to let everybody know who's coming. So maybe people can come and listen in if it might be informing across lines or that kind of thing.
Okay. We probably need to see, do we have everyone's email address that's ex officio? Probably, that we can get them.
Yeah, we'll get you a complete list of contact information for members.
Thank you.
I really appreciate the question, Vijaya, because in my view, this is how we go from 11 to being far more effective. We model the kind of recommendation number 6, partnership and integration across sectors. So once we meet a subgroup, I'm hoping folks will be strategic and robust in that outreach so that folks also are part of our movement.
So we have 15 minutes to go. Any other questions or thoughts? Otherwise, I would like for us to go out, maybe share some closing observations. I don't know what Ed had in mind for meeting evaluation, but I guess you can share them in your observations. If it's something you felt like should have been done differently. If you were in charge, what would you have done differently? That's my standard question. Why don't we start on the phone with closing observations? Magda?
All of us on the phone who've been doing this for 8 hours. The first thing I want to just start with is gratitude for Paul Jarris and for Belinda for stepping up. I've been going back and forth on text today with Ed, who's, of course, wanting to know what's going on. I just want to reinforce that he is doing well and is expected to go home to Minneapolis on Friday. And so I just want to start with our chair. An appreciation for him for how much work he did prior to this meeting to get us all in a position that we felt engaged enough and listened to enough to participate. So point one is just to acknowledge the pre-work, thank Ed and thank Paul and Belinda for stepping up today to lead us so well. My second is I love structure, and it helps me have a sense that at least there's a little bit of fluid but order to what we're doing, and I appreciate your willingness to let me put that forth to you today as something that be a starter. It's not fixed in stone, but it gets us into smaller groups to get stuff done. And then last is I did not know enough about Strong Start and what was happening on the CMS side. And when I hear that there's $43 million worth of investments that's just sitting there it reminds me that how you get from research and data to action, that translational piece is only as good as the political will to get stuff done. And so I appreciate the opportunity that we can ignite political will in strategic ways for the good of women, children, families, and fathers. Thanks for the opportunity to participate.
Thank you, Magda. Janelle?
Yes, thank you. So I also am looking forward to being able to work together and come about with some recommendations. This is a long time in coming, and all of the predecessors before us have set this up for us. So it's exciting to be a part of this stage of SACIM, and I'm looking forward to working with the group.
And thank you so much, Janelle, for participating between deliveries. So I know we know you've been busy.
I'm just really grateful to have the opportunity to be part of this, and it's been a pleasure to meet all of you. I didn't know anybody in this room before coming, and it's just great to see what people are doing and putting faces together. I look forward to our future work.
I'd like to echo what Steve said and just add to it that I just thank, as being a very new member, I want to thank everyone for making me feel welcome and just for all of your comments, and it's just been very engaging, and I've learned so much. And I think the presentations were incredible, and I can tell that there was a lot of thought that went into who you invited, and so I appreciate that. I think my only request is as a new member is it would have been awesome to maybe get some of that information a little bit more in advance, that I felt like I could have kind of prepared, just kind of viewed through that. But again, that's just me partly being a newbie too. So that was a grain of salt. Thank you.
This is Vijaya, and so I just want to reiterate that this stuff that we're dealing with is the very definition of the big, hairy problem. It's really messy work. It's frustrating as heck. It's complicated. It's slow. You start and you have to backtrack and start again. It's hard to find the right path forward. But if we can't do it successfully, we can't expect anybody else to do it, and we can't expect anything to change. So a lot is riding on our success, and I think we can do it. I have no doubt, and I wouldn't have chosen to be on this committee if I didn't think we could do it. One of the things that helps is having new information, and I think all of the presenters were very helpful in giving us some insight into some things that I know I learned a lot, and I want to thank all the presenters for contributing to that. Progress.
Much of our work is technical in nature. Much of what we discussed in the last day is technical, and that's an important part of what we do. But if we're going to take action steps to try to have an impact, echoing Magda, that's intensely political. We have to be thorough, technically smart, and respectful of the science and empirical experience in the real world. But we also need to be very curious and expand our purview, understand what politically is happening both within the department and more broadly, because reforms come in waves, and we need to maintain with our structure, with our timeline, a kind of flexibility to respond to opportunities or new obstacles that emerge, with a nimbleness that doesn't often come to advisory committees, but we have the ability, because of the people on the committee, the leadership and the support that we're getting, to be well apprised of those initiatives that are moving quickly that may be relevant to the kind of work that we hope to do. So as the working groups move forward, my hope would be as much as we're worried about technical issues, that we're also paying very close attention to things that are moving quickly and the framings that seem to have political utility at the moment.
Well put.
This is Danielle. So I'm grateful to be here once again, and I would just like to offer any support I can in terms of data, since that's what my day-to-day is. So if anyone has any questions about the infant mortality data, go ahead and you can get my information from David, and I'm happy to help in any way I can. I do not.
Well, as always, I enjoy, that's not quite the right phrase, but I appreciate being part of this committee, and everything that you guys hear and learn, I get to learn and bring back to my office as well to inform our efforts, to improve our work. And so I am interested in being engaged in different activities. So to the extent possible that my schedule allows, I wouldn't want you guys to hold up your schedule from my schedule, but otherwise I would be interested in being on one of the work groups. And I talked to David a little bit about some of the work we are doing in our office as far as evaluation of the home visiting program or early Head Start data that may be informative to this question. But I think you guys may be delving past some of that initial data, getting more to the meat of what could happen in terms of getting something done and having your actions on the table. So I'm excited to be part of this conversation. Thank you.
Thank you again for coming and for taking the time. I am not actually an ex officio member, so I will speak just broadly to let you know that from the agency's perspective, it's interesting to see that the three categories that you have come up with are very consistent with the categories that we have heard from other groups. Johnson & Johnson's been working on these activities. We internally have been doing some cross-collaboration and design work, as well as other groups that have sort of broken things down into three buckets, being access, and then the sort of disparities and equity issue, and the data issue. So those seem to be consistent across the board. There's a part of me that is very pleased to see that. There's a part of me that is hoping that you as a committee can take that and move in a direction that goes beyond where other committees are going. And I think that goes to maybe one of the points that Stephen had made a couple minutes ago about, is there a recommendation? Are there pointed things that you can say as a committee over time? We would like the secretary to do X, Y, or Z. The framework's very, very important, and I think that is what those recommendations need to grow out of. But I think where we would like to see you go is with those sorts of recommendations for advancing the field. So I'm encouraged by what I'm hearing. I'm encouraged by some of the discourse back and forth, because if everybody were just agreeing and smooth, I don't think we'd get much out of this. But I think it's a good group, and I encourage you to keep working. Thank you.
You all get a pass at the end. And I agree with Magda, as she stated earlier. You know, Ed put a lot into this meeting today, and not having him here has been, it's disappointing, but we know that Ed that we know will pick up and do even more work to prepare for the next meeting. So we all should be on the lookout for that, because he's resting right now, which means he'll have a little bit extra energy when he gets home and realize all the work we've done. I keep going back to what Jenny Joseph said, and I think all of the presentations were really great. Every time I get to hear a presentation at this meeting and others, I always feel like I pick up and learn something else that I thought I knew what the program was doing, and then I hear a different perspective on it. But when she goes back to, are we going to do anything differently, I think this is our opportunity to think about it differently and really try to focus the work and to, and be successful as we move forward. So excited about it. appreciate everyone's support today, especially after lunch. And do we need to make a motion for adjournment?
Yeah, so
Were there other people on the phone besides Magda and Janelle? Apologies. Did not mean to leave you out. Okay, we can't hear you if you're speaking. But maybe you're using this as a pass since we can't tell you're there. Thank you.
As outlined in the committee's charter, our next meeting will be by webinar, and until something changes, it will be 2 per year. You all as a committee will need to decide when you want to do that, probably late spring, early summer. Michelle Lowe will be your point of contact for travel reimbursement, but don't ever hesitate to reach out directly to me. I think you all have my email and contact information. I also just want to echo thanks from Lee and others from the federal side. This committee's charge is to advise the secretary and the administrator and the associate administrator. But what I've always appreciated about this committee is that you never lose sight that even though you're advising the committee, you understand that the work that you do is helping the families and the communities that need you desperately. So I've always really liked that. You don't lose sight of the important work that you do and how it affects not just the federal level but also at the ground. I think that's incredible that each one of you do that. And again, I started off by saying yesterday how much I appreciate you taking the time away from your family and your office, and then all that work and all that stuff continues building up while you're here. But I hope you found it to be worthwhile, and I hope that you will continue to stay as engaged as you were the past 2 days. So is there any other last closing thoughts, questions?
Just one other reminder, we still need to go back and think through the engagement of consumers to this committee. I know we did not talk about it, and we had it on our agenda for this afternoon. So I'll talk to Ed about it, and we'll figure out the best way to do it.
Right. Belinda, this is, I really appreciate you bringing that up because there's a couple of administrative issues that are not necessarily the purview of the 3 sub-working groups, but it is about how SACIM functions. And one has to do with consumer participation, and the second has to do with Paul's proposal of greater periodicity of our meetings, with Paul Jarris, that is. And so I think that when Ed is back and able to take on some more work, my assumption is that there's an administrative cross-cut across all of the work that we're doing at the subcommittee level that will look at SACIM more broadly, how often, who, how to communicate, and how to braid the work. And I just, it's invisible now, but I wanted to call that out so that your question about who is also braided with when and how often, and other administrative issues that Ed will continue to champion.
Thank you, Magda.
And anything else from anyone? Okay, well, I wish you safe travels. Thank you again, and we're adjourned.
Thank you.
Thanks so much. Bye now.
Thank you for your participation in today's conference. You may disconnect at this time.
Thank you.
Thank you.